Very good evening to all of you. At the very outset, myself and my co-chairs, we thank the organizers for giving us this opportunity to chair this important session. I think this is a very important topic about the immunotherapy in lung cancer. Although immunotherapy is a well-known form of therapy for many other types of cancer, but it is a relatively, it may not be that new, but it is a relatively new area of therapeutics in lung cancer. A lot of advances have taken place very quickly. A number of drugs are available, but I think there are still many issues. I'm sure the speakers, we have got 3 speakers, they are going to throw light on that and revise things for us. So now the first speaker is Dr. Peters. So she has achieved her MD from the medical school at the University of Lausanne in 1998. Following this, she attended the Microbiology Institute at the University of Lausanne until 2002, concluding with an MD PhD thesis on new HIV drug resistance mechanism. She is currently in charge of teaching and patient care in the area of medical oncology and thoracic malignancy at the Department of Oncology of the Lausanne University, where she is building a translational program in collaboration with the molecular oncology laboratories of the Swiss Federal Institute of Technology and the Ludwig Institute. Her main field of interest is the new biomarker discovery and validation in preclinical and clinical settings. She is also strongly involved and interested in multimodality trials, building for locally advanced non-small cell lung cancer, as well as clinical and translational cancer immunotherapy. Her current research projects as a chair are focused on multi-modality curative intent treatment of stage 3 non-small cell lung cancer, combined immunotherapy for the treatment of both non-small cell and small cell lung cancer, thymic malignancies, mesotheliomas, and denosumab in advanced forms of non-small cell lung cancer, ALK, RET, and EGFR, as well as HER2 inhibitors. So now I am pleased to invite Dr. Peters. Dr. Peters, please start your talk.
I request Dr. Smriti ma'am if she wanted to add any comments for this ESMO ISMPO session.
Yeah, so I would at the outset like to thank the ESMO for having, agreed to this symposium. And I would really like to thank Catherine Fumacelli from the ESMO side, who coordinated the whole event, and, we could put all this together. And now I invite all of you to enjoy this session, which will cover several new topics in the field of lung cancer. Thank you.
Now I request Dr. Solange Peter for her talk. Over to you, Dr. Solange.
Dear colleagues, it's my great pleasure in these 15 minutes to discuss with you some data about immunotherapy in advanced lung cancer. The question, and that is the one I will address, is a bunch of new data. Is newer data of value or just repetition? So you have understood, I will focus on the 2021 new data and try to put them in the context. This is my disclosure slide. First of all, remember about new data, new strategy, new compounds, that we now have identified some of the parameters which dictate immunotherapy sensitivity. For example, high PD-L1, high TMB, interferon gamma expression, or immunotherapy resistance, for example, IDO activity, adenosine pathway, VEGF. So we know more and more about potential biomarkers and potential new strategies. That's a glimpse of hope. We also put on this map of the immune cycle. Remember immune cycle with all of the steps to develop an anti-cancer response. We put new compounds on the map. This is the updated one. So we have hopes for new combinations, new data, which will really change the landscape. Is it already the case? Well, you'll see, at least not so much. So first of all, looking at immunotherapy in lung cancer, is still basically focusing on two synapses, one during the priming phase of the immune response, the CTLA4, one during the effector phase of the immune response, the PD-1, PD-L1, with a series of compounds, two anti-CTLA4, but a growing list of anti-PD-1 on the top or anti-PD-L1 on the bottom. So the question, first of all, we've seen many data with new anti-PD-1, anti-PD-L1 last year. Does it really change the game? So very importantly, are there biological differences between new and old anti-PD-1 and anti-PD-L1? The answer is yes, of course. There are biological differences. They can be IgG1, they can be IgG4. They have different half-lives, as you can see, and they are characterized by different, I would say, affinity for the Fc gamma receptors, remaining leading to antibody-directed cell cytotoxicity or complement-directed cytotoxicity. So there are biological differences. They will differ in terms of level of PD-1 occupancy, volume of distribution, toxicity profile, and as I said before, serum half-life. However, today, in the practice, in the daily practice, I must state that none of these biological differences has translated into a real outcome difference. So today, this is more a repetition and not really, I would say, an innovative context or concept to be taken over with this new anti-PD-1, anti-PD-L1. So that's where we were basically at the beginning of 2022, with, as you can see, on the left-hand side, non-squamous, on the right-hand side, squamous, and a series of options, IO chemo, IOIO, IOIO chemo, and in high PD-L1, IO monotherapy. Of course, all of these schedules has been completed by this new anti-PD-1, anti-PD-L1. You can see that the market is now defining a market for them and across many diseases in various continents. But as I said before, I don't think it will change the science and the outcome, but it might change the accessibility. So in terms, and this is an example of in frontline therapy, how this new cemiplimab, camrelizumab, sintilimab, tislelizumab, sugemalimab, sorry for all these names, have reproduced, repeated, mirrored what was existing before in other trials. So no real advances, but maybe a larger accessibility. So what I'd like to discuss with you today is maybe some things which have changed. So what is important for me in this graph is in yellow, Empower Lung 3, Checkmate 9LA, and Poseidon. And I'd like to discuss these three trials, which I think is not repetition. So first of all, let's speak about this standards of care we have. Usually you use chemotherapy per checkpoint inhibitors. You remember that this is a standard option in adenocarcinoma based on 3 trials, adding pembro, adding atezobev, or adding atezolizumab, right? And this is the kind of curve you observe as a standard of care with chemo IO in non-small cell lung cancer versus chemo frontline. So this is the backbone of what we do. And this remains valid across all strata of PD-1 expression, negative, intermediate, or high. So that's one of the option standard that we have to keep in mind because this is the comparator. We have the same data in squamous non-small cell lung cancer, but I just would like to say that it's only one trial positive with pembrolizumab again. And I wanted just you to look at how the standard defined differences in survival. But if you look at the difference in survival in negative PD-L1 patients, you will agree with me on the right-hand side that these negative PD-L1 patients benefit, I would say, marginally or at least less from the combination of chemo and IO. I just wanted you to keep it in mind because of the changes we will bring with the next trials. So first of all, the Empower Lung 3 was a good trial because it was addressing the addition of an anti-PD-1, cemiplimab, to chemo in all histologies. So meaning in all incoming non-small cell lung cancer with no oncogene addiction, whatever PD-L1, you could treat them with cemiplimab plus chemo, with all the potential backbones of chemo that we usually use. So it's a very real-world clinical trial. And what is good in that trial, it doesn't really change, but it tells us that IO has to be added in all coming non-small cell lung cancer, and that they can reproduce what was partially represented across previous trials in a large trial without selection. And as you can see, a very strong confirmatory trial. What is interesting here is, again, what I said to you before. I want you to look at this waterfall plot for one thing, is the confirmation that negative PD-L1 patients only marginally benefit from IO chemo versus chemo, and we need to do better there, right? The other thing here, which is important to remember, is the addition of IO is not a very strong efficacy in never smokers. So maybe new data because it reproduces, it goes for all lung cancer, and very importantly, we still struggle with this negative PD-L1. This is data of Empower Lung 3 put in the table, so you can have them, you can look at them, and that's how this new data was presented. But now, what I would oppose to this skeleton is the IOIO chemo trials. So the first of this one is 9LA. 9LA is IOIO, EP-Nivo, remember EP low dose, and chemo, short duration chemo, only 2 cycles. So Nivo EP for 2 years maximum, and only 2 cycles of chemo versus chemo. All patients, regardless of PD-L1, could be enrolled without actionable alteration. Primary endpoint OS. What is good, 2 cycles of chemo, overall survival benefit for Nivo EP chemo versus chemo, hazard ratio 0.72, and no early deaths, so no risk of early progression when you give 2 cycles of chemo. So now look at my subgroups when you use IOIO. So first of all, PD-L1 negative on the bottom of the slide look like to be recovered by the use of CTLA-4. Jim Allison had shown it before. The CTLA-4 induces expression of PD-L1. Importantly, it looks to have an incremental effect as compared to the control arm in patients with CNS mets. So potentially really having a specific activity CTLA-4 when you have brain mets. And as you can see here, again, the never smoker have a difficult story. Keep in mind here that squamous and non-squamous benefit, but if anything, squamous is slightly better than non-squamous, but let's say they both benefit, okay? The activity is therefore, as you understood, conserved in negative PD-L1 tumors, so way better than chemo IO, and it might be a way to move. Why would it be the case? Potentially, somehow you have to keep in mind from melanoma and now 7 papers that when you give CTLA-4, you broaden the repertoire of T cells. So it might be that, first of all, you encompass the recognizable feature of some new neoantigen, maybe in the brain, maybe in PD-1 negative tumors, maybe in general, potentially leading to memory T cells and a longer duration of treatment. And when you look at the brain, look here at the curve. This is overall survival in patients with or without brain mets in 9LA. You can look how much there is an incremental, another layer of activity in patients with baseline brain mets. In that trial, they were treated and asymptomatic. And as you can see here, very impressive to see the disease control rate at the brain level in these patients with the CTLA-4. And I love this intracranial PFS, which leads to a hazard ratio of 0.736 with Nivo EP chemo versus chemo. So really something in the CTLA-4 here. The second trial, which was a change last year, is Poseidon, where it's the same strategy of platinum-based chemo as a control arm and an arm with durva-tremi chemo. There was a primary arm of durva plus chemo, but as you can see, a very complex statistical strategy, which was mainly basing on the durvalumab plus chemo. But unfortunately, this arm failed. If you look on the right-hand side, the durva plus chemo versus chemo failed, but there was still an option to continue with 1% of the alpha for durva-tremi chemo versus chemo. You can see at the level 2, which was further conducted. So the usual chemo IO failed, but the chemo IOIO was successful. It was, be careful, a secondary endpoint. So this is durva chemo. As you can see here, the PFS was improved, but not the OS. So we can say it failed because you won't nowadays an OS benefit. But when you see at the durva-tremi chemo versus chemo, here PFS is significant and OS is significant. You don't have early deaths, which is a progress as compared to many IOIO trials. And I want you now to look at my advances, because now you can compare durva chemo to durva-tremi chemo. So if you look at negative PD-L1, TC less than 1. So when you use Durva chemo versus chemo, you don't have benefit, like I said before. When you add the tremelimumab, maybe because of the expression of PD-L1, maybe because of the neoantigen recognition, you save this subgroup of negative PD-L1. That's very important. And again, in that trial, you can see the other subgroups as before. But interestingly, in that trial, squamous were doing slightly worse. Let's go into this graph. This is OS in non-squamous and in squamous. And you can see that in squamous, it's difficult to decipher a benefit of the 4 drugs regimen versus chemo. Difficult to understand why. The gemcitabine treated patients were not doing well with durvalumab, but still to be understood. But basically, an interesting trial to add to our data set. Real advances have come from CTLA-4, brain, negative PD-L1, and who knows, based on melanoma, maybe duration of benefits. But the real advances will come from innovative IO agents. And here's a wonderful review telling all of the mechanisms we have in terms of new drug to try to further activate the immune system, starting by the chemokine manipulation, but also all the microenvironment modulation, metabolism inhibitors, immune effector cell modulators. So really something which is now moving in phase 1 forward. This is the usual review in Nature about how the market of drugs is developing. And you can see that based on a skeleton of anti-PD-1 and anti-PD-L1, there is a wide range of new compounds which are now used to try to really improve the combinatorial opportunities in non-small cell lung cancer. This is a list of the upcoming phase 3 trial with novel agents in frontline metastatic non-small cell lung cancer, adding the anti-IL-1 beta canakinumab to pembro chemo, adding PARP inhibition, trying to reach antithetic lethalities using olaparib or niraparib, adding anti-angiogenic lenvatinib, or adding anti-TIGIT in high PD-L1 tiragolumab. So these trials will come and will be very interesting to improve our knowledge. And with this, I thank you for your wonderful attention.
Thank you so much, Dr. Solange Peters, for a wonderful lecture. And as usual, we had many of those interesting things to pick up from.
Yeah, go ahead.
So we had some queries, so I'm sure you take it up. So when we want to use these monoclonal antibodies, which test does it matter, or we can exchange anyone? Till recently we were comfortable, we had one drug, various ways of using it, but you did show that we need to be a bit careful about it.
Yeah, so basically we have been doing this effort. We have been pioneers in lung cancer to try to understand how to measure the expression of PD-L1. We've been struggling a lot, probably for 2 years, trying to establish how to do that. Because as you said, every company was coming with their drug and their test. So it was a huge mess. So what we did in the ISLC, the International Association for the Study of Lung Cancer, with the pathology group, we made this blueprint project, which was a way to compare how you can score with one assay as compared to the other one, the one from Roche as compared to the one from AstraZeneca, and so on and so forth. And basically the answers is they are more or less all comparable. So they are all more or less all superimposable. But basically, if you really look at how standards have been reached, you need to make sure that you use a test which is validated. So they are comparable. You can use one for the other one. Particularly now is the 22C3 and the 263, which are used, right? But there might be other ones because you remember in the world, many centers use their own test, what we call the laboratory developed test, right? The LDTs. So if you use your test, please compare it to a standard test initially to make sure it's okay. But basically, all in all, PD-L1 is heterogeneous and dynamic. So if you have a good test well compared to 22C3 or 263, then you can move with your LDT, your laboratory developed test, without any problem. So I think we have gone through this struggle of testing by establishing good standards.
The next question from my side, will be regarding brain mets. That data is again looks very good. What could lead to that? So a Nivo EP in PDL1, you explained the reasoning. What could be the hypothesis that in brain mets that difference was very good, and as compared to what we have seen otherwise?
Yeah, I agree with you. It's quite amazing, right? Because it's the same in melanoma. Remember that Georgina Long has shown in many trials. The last one was at ASCO this year, 21, the ABC trial, where Nivo EP is way better than Nivo in brain mets of melanoma. So there's really something correct across diseases, right? So what is probably the hypothesis is two things. First of all, maybe by enlarging the diversity, the repertoire of T cells, you might recognize a larger number of cancer cells. So just by making the sensitivity of the immune system higher, you might improve even in niches like the brain, which is something difficult. Remember, the drug doesn't pass the blood-brain barrier. Only the T cells can travel. So maybe you make travel a more diverse population of T cells if you have CTLA-4. But it is a debatable kind of argument. I would rather think that using CTLA-4 might at the end change the microenvironment. And remember that the brain has a very strange microenvironment around the tumor cell. Just think about the antigen presenting cells, which are the Langerhans cells, right? So probably the whole CTLA-4 concept is changing the paradigm of the microenvironment of the tumor, making the brain more sensitive to immunotherapy. Remember, on the other hand, that glioma were never reachable by any IO. So there's something in the brain which makes this environment not favorable to immunotherapy. And this might be the microenvironment. So
you think maybe if they use combination in glioma, they have a chance?
They are trying, right? They are now trying to do more and more combinations. Glioma, of course, remember, is also a lower neoantigen load, but it's really difficult. Remember, in glioma, the difficulty is you need to mount the immune response in a tumor which is located in the brain. When you have a lung cancer, you mount the immune response in the lymph node, in the tumor. So the drug is getting there very well in your lymph nodes, in the lung tumor. So you can mount a T cell response. When you think about the brain, the EP and the Nivo does not really reach the place where the tumor is because it doesn't cross the blood-brain barrier. So it's really a challenge, right?
Absolutely, I agree with you. So next question is, and what you showed consistently, that if a PD-L1 expression is not there, looks like alone this drug doesn't work. Not based on approval. What is your thought process on second line Nivo? Do you think it's the waste of giving it? In PD-L1 non-expression?
Mm-hmm. Well, I don't think it's a risk. Well, PD-L1 negative, everything you do is less efficient. You could not say it's absolutely inefficient because remember, PD-L1 is somehow heterogeneous. So it might be, well, when you have PD-L1 negative tumors, remember the 3 phase 3 trials in second line, even negative PD-L1 look like extracting some benefit, less, but some benefit. Is the reason that you missed some PD-L1 somewhere else in the tumor, or is it because there are other parameters, TMB, Tregs, MD, myeloid-derived suppressor cells? I don't know. But PD-L1 negative have a benefit, but a smaller benefit of the strategy. But I guess you need to try. Because even in PD-L1 negative, you will end up with 5 to 10% of your patients telling you 10 years later down the road that you told him he will die or she will die. So, 10% long-term survival is something. But I agree with you, the probability is lower, but you still need to try. What is good and what Jim Allison has shown before the Nobel Prize is if you have a chance to give anti-CTLA-4, it will make an interferon gamma signature exist, meaning the PD-L1 expression exists. So that's where the combination might be interesting.
Thank you. And my next question will be, have we given up beyond KRAS for mutation positive patients for immunotherapy, or you think, no, we will be getting something on, as the time goes by, initially we thought it's only EGFR, then we now ALK is also something where immunotherapy is pretty questionable. ROS1, or are they differential, or do we put in the same basket apart from KRAS?
Yeah, it's a very, very good question. I would say KRAS is a good candidate. Remember, if anything, when you have a KRAS mutations, it's usually a smoker patient, so you have a very strong efficacy of IO. So KRAS is a good player. But the other ones, RET, ROS, MET, BRAF, HER2, ALK, and EGFR, are usually found in never smokers. And never smokers are patients who present with a low neoantigen burden. So probably they are all in the same bag because of biology. So biology is a very small number of neoantigen. However, remember, we have some data that if you have a BRAF mutated patient who is a smoker, or if you have a MET exon 14 skipping mutated patient who is a smoker, that suddenly immunotherapy might work. So there's really something about this never smoker story, right? Which puts all of them in the same bag. Have we given up? Well, again and again, it's not that there is zero activity, but you need to divide the activity by 2 or 3. So instead of having 20% response rate, it's probably more between 5 and 10% response rate in these patients. And the gain in terms of OS and PFS becomes pretty marginal if you think about sustainability of our health systems. So I would say we have not given up, but immunotherapy is not an early line strategy because the magnitude of benefit is very small. However, I'd like to rediscuss the EGFR because, of course, EGFR is TKI, maybe amivantamab if you are in a country where there is a trial. There are many lines of targeted therapy. But remember that there was this IAMPOWER 150, which was showing that specifically in EGFR mutated, giving chemo, IO, and bevacizumab was better than chemo, but was also better than chemo and bevacizumab, or better than chemo and IO. So really the combination of IO and bevacizumab being interesting in that disease. It was really put into question because it was an exploratory subgroup. It was retrospectively done. So it was questioned by many people. But remember, at the ESMO plenary 2 weeks ago, we had the Orient 31. It's a trial by Dr. Liu, remember, from Asia, who was showing again the same thing, right? Trying to use sintilimab, pemetrexed, and an anti-PD-1. They was able to show that basically, again, IO anti-angiogenic, an anti-angiogenic, IO and it's called IBI305, this is the anti-angiogenic. Sintilimab plus an anti-angiogenic plus chemo is really giving an option in EGFR mutated. So I'm start to really believe, I don't know about you, that in EGFR, IO and anti-angiogenic might be the way to move. So now I'm pretty convinced, and this data from the Orient trial is pretty amazing, right? So maybe there's something to explore, and maybe we'll get some other things for other diseases in the future. What do you think?
Yeah, I think so. I agree with you because the kind of disease we deal with, we all want to stick to whatever little hopes we get, and sometimes that hope becomes a bigger one. I'll take a minute or two of more of yours. One is that we do have now good data with PDL1 and then CTLF4. Do you think the other, which we have heard a lot, that's a LAG3, TIGIT, all other checkpoints, what kind of data we have, or do we think that it is going to take time?
Yeah, it's going to take time. What I mean by that is LAG3 is now in investigation. You remember it was breaking news in melanoma, right? It works very well in melanoma. By the way, it competes with CTLA4 because it's so good that it's a real competition, but it's ongoing in lung, right? In lung, there are trials ongoing with chemo plus IO plus LAG3. Remember, every company has LAG3. So this data will come. We are more at the step of feasibility, but they will come. For TIGIT, it's the same thing. We have trials with chemo atezolizumab. We have trials with atezolizumab, which are ongoing and should read in the next 2 years. So we are just a little late, but I still hope really that these other, we can call them other checkpoints, right? These other checkpoints might be good ways to move in lung cancer too. So I'm pretty, I would say, optimistic about the potential use in lung cancer. We are just a little late. What was a little failure was the cytokines. We've been moving a lot with, trying to manage the cytokines with pegilodecacin, canakinumab, and so on and so forth. And at the time being, none of this cytokines manipulation did work. So that's maybe one thing which we are weaker than we thought. It's about how cytokines can really change the environment.
One last question. The neoadjuvant data, I remember you discussing about it, and you were very excited, and I totally agree. 3 cycles, good enough, especially we coming from developing country. Are we giving immunotherapy more than required? Never ending, and the patient gets fatigued.
Yeah.
That 3 cycles, the data, event-free survival data is not out, but company has put in press release, looks good, looks positive.
Absolutely. So no, I fully agree with you. We might never have the answer for advanced disease because it's not in the advantage of the pharma industry to show that you can make it short. But and if you agree, probably if we had to do a trial, we should differentiate the patients who respond to the ones who have stable disease, because I'm pretty sure that having a very good response or a complete response defines a group of patients in which you could stop quite early, like in melanoma. Remember, in melanoma, when they reach complete response, they do 1 or 2 more cycles and they stop. So we might also do something like that at some point, but I'm not sure we will have this data at any time point. So in countries where sustainability might not be reached, I would rather say that stopping is not the way to move, but the interval might really be prolonged. Remember the phase 1 from Julie Brammer in the JCO in 2015. She was really showing that after 2 infusions, you have a pharmacodynamic plateau for 100 or 200 days. So instead of stopping, I would rather make the interval longer if you cannot afford the 2 years of IO. So I really think that we are more home brewing here than evidence-based, and we might never have evidence-based.
Then maybe I'll add to one question and the real last one. And you want to comment about dosing? So good, you commented about the interval part. So people getting ideas about dosing is also a good idea to explore. That
Yeah,
maybe
yeah.
rather than giving the dose what we are giving today, maybe 1/10 of the dose or 1/4 of the dose, or
yeah, these are all the things we should do. What we could do as academic groups at some point would maybe not be to do big trials with 400 participants, because we will not be able to finance them. But we could try to do good pharmacokinetic trials, right? Trying to understand at each cycle, like pharmacokinetics can be do, pharmacodynamics, what it makes to give half of the dose, or what it makes to give full dose every 8 weeks. So I think as academic groups, what we could move to is carefully try now to do real pharmacology, because pharmacology at the end is the basis of everything, right? If the drug is here, then you can really understand how it acts.
It was a really nice presentation, Dr. Peter Solens. Any other last comment from your side?
No, thanks a lot for having me. It's a great pleasure to meet you.
Same here. Thank you so much. I enjoyed your talk. I'm sure all our
Thanks
audience.
a lot for having me. Bye-bye.
Thank you. Bye.
Now I request Dr. Lisa Hendricks, ma'am, to invite the next speaker. Can we have the next speaker, please?
Yeah. So thank you for inviting me, and it's a pleasure to announce Dr. Tilak with a talk about second-line therapy after immunotherapy. are there any specific choices? And I think it's a very important topic because most patients will get first-line immunotherapy, and we know that most patients will not benefit. So I think also research in second line and beyond remains very important. And Dr. Tilak, he's a professor in medicine and a medical oncologist at the Armed Medical Forces Medical College, Pune, and I hope I pronounce it correctly.
Yes, correctly.
Thank you very much for the invite. And while I share my screen, I'd like to place on record my gratitude to the organizers for giving me this opportunity. And over the next 10 minutes or so, I should be speaking about the second-line therapy after immunotherapy. Are there any specific choices? Greetings from my institute, the Armed Forces Medical College at Pune. So when the immune checkpoint inhibitors are used in the first line of therapy, as a single agent, they have a response rates of around 20-30%, whereas in case of a combination with a chemotherapy or an immune checkpoint inhibitor combination, it's a response around 50-60% is there. What depends on the therapy beyond the second line are the factors mentioned on the slide. The previous therapy the patient has received, the type of the response, whether the progression is oligometastatic or a systemic kind of a progression, what is the burden of the disease, and what is the patient performance. So the progression on this combination can be classified into three main kinds of classes. The early systemic progressive disease, which is within 3 months of initiation of treatment. The intermediate systemic progressive disease, which is 3 months to 2 years of initiation of treatment. And late systemic progressive disease, which is at least 2 years after initiation of the combination therapy. So we'll stick to the agenda in the following three main headings. What are the second line options prior to when immune checkpoint inhibitors had come into the foray? What are the data for options of use of drugs after second line immune checkpoint inhibitors? What has been happening so far? We used to use a platinum-based chemotherapy, second line use immune checkpoint inhibitors. What beyond that? And what is the data for first line immune checkpoint inhibitors followed by a second line options? So coming to the second line options prior to immune checkpoint inhibitors, for combination therapies, we had the docetaxel plus ramucirumab, the docetaxel plus nintedanib, and paclitaxel that is weekly, along with bevacizumab, and of course various single agents like gemcitabine, pemetrexed, single agent docetaxel, or even afatinib in squamous cell carcinomas. So the REVEL trial data showing the docetaxel plus ramucirumab versus docetaxel plus placebo compared these two in stage 4 non-small cell lung cancer who had received prior platinum-based chemotherapy. And there was a modest 1.5 months improvement in the PFS, but also improvement in the OS, which was statistically significant, though the duration was very small. Similarly, the LUME-1 trial used the nintedanib along with docetaxel in patients who had already received first-line platinum therapy, compared with docetaxel with placebo. And here again, as we can see on the right side, the overall survival in the adenocarcinoma was quite significant, with about 3.5 months of overall survival benefit, and also a small PFS benefit in the entire intention to treat population. So this slide shows the comparison of the various response rates, the median PFS and OS for single agents as well as for the combination therapies in the second line setting post platinum-based chemotherapy. And we can see that the combination therapies have got a better OS and a PFS advantage. A very busy slide, but a good slide just to compare the various options available for treatment in the second line on the x-axis versus the same on the y-axis. It is a kind of a heat map where the ones in the blue are showing the negative kind of results, whereas the ones in the yellow show positive results, and one in the red showing the most best results of all the second line therapies available post platinum-based chemotherapy. Coming to the second line options, or rather third line options after second line use of immune checkpoint inhibitors. So does chemotherapy after immunotherapy offer a better overall response rates? So there were a few studies, and I'll show a couple of them to show that the chemotherapy after immunotherapy does offer a better overall response rates. So published in 2017, this data are the small numbers, 28 patients, with the overall response rate after immune checkpoint inhibitors was about 39%, whereas prior to immune checkpoint inhibitors, the response rate was about 37%, just a numerical advantage. Another paper published in 2017, again showing whether the salvage chemotherapy administered after immune checkpoint inhibitors has an increased response rates. Here, they had about 73 odd patients, and they showed that the chemo in doublet after immune checkpoint inhibitors has got a higher overall response rate than to the last chemotherapy before immune checkpoint inhibitors. Again, both single as well as in doublet, the overall response rate is higher, both statistically significant. So it proves that the overall response rate for salvage chemotherapy after immune checkpoint inhibition is significantly higher than the last chemotherapy before immune checkpoint inhibition. Now coming to the data for second line options after first line immune checkpoint inhibitors. So the two studies recently published 2020, 2021 treatment of first line immunotherapy options after first line immunotherapy. They were there, they did show some benefit. I'll just come to that. Just going back to the combination of docetaxel and ramucirumab in the second line setting after use of chemoimmunotherapy. So now we're talking of the same kind of combination after a platinum combination and now talking after immune checkpoint inhibition. So here they used it as a doublet in 18 cases and a single agent ramucirumab in 15 patients. Overall response rate of 55.6% with the doublet. What they found was patients who had had a response of more than 8.8 months with chemoimmunotherapy had a very high PFS advantage as compared to those patients who had less than 8.8 months of response after PFS with chemoimmunotherapy, which means that the duration of response to chemoimmunotherapy may allow us to use this combination in these patients. The previous speaker very beautifully alluded to the tumor microenvironment and what happens at the tumor microenvironment. So whenever the tumor grows, there is intratumoral hypoxia, leads to production of the hypoxia-inducible factor, leads to the production of the VEGF, and leads to the abnormal vasculature, the malformed and malfunctional vasculature in the tumor. Now this abnormal vasculature leads to some kind of an immunosuppressive effect. There is effect on the endothelial cells, there is reduced antigen presentation by the dendritic cells, there is polarization of the tumor-associated macrophages where they move in from an immunosupportive to an immunosuppressive kind of a phenotype. And of course, there is increased production of Treg cells, all of these adding to immune suppression. So does the immunotherapy, which is given in the first line setting or even the second line setting, does it modify the microenvironment for an anti-VEGF? This was pointed out very beautiful in the previous speaker, Dr. Peters. Just let's look at the relation between the VEGF and the immunotherapy agents. There is a relation where the use of immunotherapeutic agents leads to an interferon gamma mediated vascular remodeling. And this adds to some amount of effect with the anti-VEGF. Thereby, the use of anti-VEGF in the second line may lead to further remodelation of the tumor microenvironment and causing immune trafficking, leading to a better response with a rechallenge probably with immune checkpoint inhibitors. But is there data to that? So there is this paper which has used the same docetaxel and ramucirumab following second line immune checkpoint inhibitors in non-small cell lung cancer. And this table has compared the docetaxel nintedanib and docetaxel ramucirumab in a single table. The arrows point to the third line use of these drugs post second line ICI. What you can make out is the very high disease control rates and the response rates compared to the second line therapy which was used. So it does mean that when immune checkpoint inhibitors have been used in the second line, the use of anti-VEGF drugs beyond that does have an increased response rates as well as disease control rates. So the use of immune checkpoint inhibitors leads to some kind of a vascular normalization, thereby enhancing the effect of anti-VEGF. The use of anti-VEGF agents used to an immune activation, leading to a better effect of the immune checkpoint inhibitors. Using them in combination is what was a previous speaker alluding to, does have a benefit of using in the tumor microenvironment, and that explains the effect. So probably we are seeing a new sequence in the horizon where we use chemoimmunotherapy in the first line, which leads to modulation of the tumor microenvironment, allowing the chemo plus anti-angiogenic therapy agents to act better. And this anti-angiogenic therapy, when it modulates the tumor environment further, we may have a better option to re-challenge with immunotherapy.
20 seconds.
For ICI beyond progression. And atezolizumab, the data with pembrolizumab as well as with nivolumab, but this slide just showing the atezolizumab beyond progression, showing the increased survival advantage even beyond progression. A lot of newer agents, due to lack of time, I just put on one slide. The lenvatinib, plus pembrolizumab versus docetaxel being compared in a phase 3 trial. The sitravatinib, again, multi-agent kinase inhibitor against TAM family, as well as the regular VEGF and the PDGFR alpha, showing a disease control rate of 84% in initial trials. Cabozantinib is being tried in a phase 3 trial. And of course, the IL-2 agonist is being tried with pembrolizumab in a PROPEL trial and with nivolumab, as well as with nivo-ipi combination in PIVOT 2 trial. To summarize my last slide, whenever there's a progression to a non-small cell lung cancer patient after use of immune checkpoint inhibitors or with combination chemotherapy, if there is an oligoprogression, maybe the local ablative therapies can help in maintaining the response. If there is systemic progression, if there is a primary resistance, there is early progressive disease, these patients require probably a clinical trial or a rebiopsy to see the change in the morphology. If there's an acquired resistance, if it is an early or an intermediate progressive disease, various combination strategies with the anti-angiogenic therapies can be tried. If it is a late progressive disease, beyond 2 years, beyond 1.5 years, progressive disease terminating after ICI, we can re-challenge the immune checkpoint inhibitors, or progression during the therapy, we can re-challenge with a change of the chemotherapy. With this, I finish my talk, and if there are any questions, I'll be more than happy to take them.
Thank you so much, Dr. Tilak. Now I request Dr. Vijayanand Reddy, sir, to invite the next speaker.
Hi, good evening. Thank you, Dr. Smriti, for inviting me as one of the faculty. It's very interesting. Immunotherapy in lung cancer has brought we all know it's a major paradigm shift in the lung cancer management, but there are still so many unanswered questions. And it was very, very interesting to listen to Dr. Peters and Dr. Kumar's discussion. Now we have a last talk in this session, which is very, very interesting. Biomarkers in immunotherapy. Are all of them required? We have a wonderful speaker, Dr. Navneet Singh. I heard him several times. He's a wonderful speaker, and he is an additional professor, Department of Pulmonary Medicine, PGI Chandigarh. Over to you, Dr. Navneet.
Dr. Reddy, he's a professor now, not additional professor.
That's been there in the...
no, it is okay.
Yeah, congratulations on your promotion. You're a Professor, Department of Pulmonary Medicine, PGI Chandigarh. Over to you, Dr. Navneet.
Thank you, Dr. Chairpersons. And at the outset, I'd like to thank Dr. Smriti and ISMPO organizers for inviting me for this talk. I apologize for any overlap with the previous speakers. Good evening, everybody. The topic which I am going to talk about today is biomarkers for immunotherapy. Are all of them required? I have no conflicts of interest. And I will do the talk in the following headings. First, what is a biomarker? Why have a biomarker? And then which, when, and how are the biomarkers for immunotherapy in lung cancer? So definition of a biomarker is a characteristic that is objectively measured and evaluated as an indicator of either a normal biological process or a pathogenic process or a response to a therapeutic intervention. A prognostic biomarker is a biomarker that forecasts the likely course of disease irrespective of treatment. On the other hand, a predictive biomarker is one that forecasts the likely response to a specific treatment. And validation is the process in which you have confirmation by robust statistical methods that a candidate biomarker fulfills conditions which are necessary and sufficient for its use in the clinic. Now, if you can see that there are biomarkers which can be purely prognostic, ones which are purely predictive, or ones which are both prognostic and predictive. What is the need to have a biomarker for immunotherapy? Well, biomarker that helps predict a response to or effectiveness of immunotherapy is needed because these are very expensive drugs with no generics till date, and therefore appropriate patient selection is the key to minimize treatment costs, minimize potential immune-related adverse events, and maximize cost effectiveness, and basically avoiding it in those unlikely to benefit and using it in those who are likely to benefit. Now, if you look at the host tumor interactions, you can see that there are several potential biomarkers for immunotherapy. We are well aware of PD-L1, tumor mutation burden, tumor infiltrating lymphocytes, and tumor gene signatures. Now, if you look at all of these biomarkers, what you can see is that the one which is the simplest to actually find out is PD-L1 expression based on immunohistochemistry, while for all of the others, it is more complex, going up to gene sequencing or big validated assays. And therefore, let's focus on PD-L1 testing. Now, as you can see that whether it is monotherapy or immunotherapy, chemotherapy combinations, it is PD-L1 which has been the hallmark as a biomarker for immunotherapy. And of course, in the Checkmate 227, both PD-L1 and TMB were assessed. And if you look at the results, the current standard of care, which is a high PD-L1 treated with monotherapy, you can see that it performed very well. On the other hand, for the combinations of immunotherapy and chemotherapy, PD-L1 cutoffs really did not make that much of a difference. Now, if you look at this part by a meta-analysis and individual patient level analysis, you can see that the survival was correlated very well with PD-L1 expression. For PFS, high PD-L1 did much better than low PD-L1. And similarly, if you look at OS, high PD-L1 did significantly better with as compared to low PD-L1, with hazard ratios of almost 0.41 for PFS and 0.62 for OS. However, if you looked at durable clinical benefit versus non-durable clinical benefits, it is clear that PD-L1 expression alone was insufficient. And we know now that there are genes like KEAP1 and STK11, which may portend resistance to immunotherapy. On the other hand, you may have genes like RYR1 and MGAM, which may enhance the efficacy of immunotherapy. Of course, you can go into more detail with this ISLC Atlas of PD-L1 testing, and also read this Blueprint Phase 2 project, which tried to harmonize these assays. Now, this part is very important because if you looked at the dominant IHC clone which is used, it is 22C3 in North America, Europe, and Central and South America. On the other hand, for Asia, where we live, and Oceania, it is actually SP263. So regarding PD-L1, the key takeaway points are that PD-L1 expression on tumor tissue by immunochemistry remains the most commonly used predictive biomarker for immunotherapy in non-small cell lung cancer. High PD-L1 advanced in metastatic disease without an oncogenic driver, as shown in Keynote 024 and Empower 110. And even for the adjuvant treatment of completely resected early stage NSCLC in the Empower 010 trial, and maybe even for consolidation treatment of locally advanced unresectable stage 3 NSCLC, the Pacific trial, in which PD-L1 also tended to predict who did better. Now, the predictive role of PD-L1 is more important clinically when immunotherapy is being planned as opposed to chemo-immunotherapy combinations. But PD-L1 determination is affected by both tumor characteristics, that is tissue heterogeneity, sampling site, etc., as well as by testing variables like the method used, intra and inter-observer variability. Coming now to TNB, this was the Checkmate 227 trial, and this was a rather complicated trial with 6 arms, and it had 2 co-primary endpoints. One was PFS in population selected on the basis of TMB, and OS in population selected on the basis of PD-L1 expression. So the primary endpoint for PFS was met with the dual immunotherapy combination as compared to chemotherapy with a hazard ratio of 0.58. However, if you looked at overall survival, the most interesting observation was when you looked at various PD-L1 and TMB combinations. And of particular note was that patients who did not have PD-L1 expression but had a high tumor mutation burden of more than 10 as defined in this, they seem to derive the maximal benefit with the best hazard ratio of 0.51. However, a more recent paper shows that high TMB fails to predict immune checkpoint blockade response across various cancer types. And what they found was that it is actually the CD8 antigen which really matters. And so you have categories in which CD8 positively correlated with neoantigens and category 2 in which it did not correlate. And if you looked at this, whether it was squamous or adeno, TMB really did not make a difference in terms of overall survival. And what really mattered was the patients who were in category 1. Now, this was true whether TMB was taken as a binary expression or if it was taken as a continuous expression in which it mattered both for overall survival and objective response rates. Now, there is always this talk of whether you can do the same thing in liquid biopsies. Also, we know its advantages being a non-invasive procedure and allowing a more global assessment of the biomarker. And therefore, both PD-L1 and TMB have been attempted in liquid biopsy. Now, this was published in Nature Medicine by Dr. Gandara and colleagues. And here, blood-based TMB was used to predict clinical benefit in patients treated with atezolizumab, a PD-L1 inhibitor. And so the blood was taken, plasma isolated and cfDNA extracted, and BTMB determined and then used first in a training set in the Poplar trial data set, and then validated in the larger OAK trial. Now, the correlation between blood TMB and tissue TMB is depicted here, and you had shared variants in 60% of the cases, but you had cases in which it was only in tissue around 25% and a similar figure only in blood. Now, if you looked at PFS, the benefit for atezolizumab as compared to docetaxel, remember this was a second line trial, the BTMB more than 16 was the category shown to have the benefit. However, OS, everyone seemed to benefit irrespective of the BTMB cutoff. On the other hand, if you looked at various cutoffs, you can see that with increasing BTMB values, the magnitude of benefit did seem to improve, with the highest benefit for both PFS and OS being seen in the highest BTMB cutoffs. Similarly, PD-L1 expression has been tried on circulating tumor cells. And what you can see is that in patients who had high PD-L1 CTCs, they seem to derive better benefit with the proportions of partial responses and stable disease much better than in those without PD-L1 high CTCs. And if you looked at both PFS and OS and tried to look at different cutoffs, it was clear that if you had high CTCs with PD-L1 expression, the benefit was more marked. And that was true whether it was monotherapy or combination treatment with chemotherapy. Now, there has been a hype cycle postulated for predictive biomarkers for immunotherapy in lung cancer. And this has basically gone through a phase of technology trigger, a peak of inflated expectations, then a trough of disillusionment, then a scope of enlightenment, and finally a plateau of productivity. And I think it may not be wrong to say that PD-L1 has reached this point, and TMB is actually on the down at this point, and the other genomic signatures and TILs are probably at this point of time. And so to summarize, tissue PD-L1 expression, despite all its limitations, is still the most commonly used biomarker to guide immunotherapy in non-small cell lung cancer. Other explored biomarkers include TMB in both tissue and blood, tumor infiltrating lymphocytes, and gene expression signatures. And the search for an elusive, near perfect biomarker for immunotherapy in lung cancer continues. Thank you very much.
Thank you to the chairpersons, Dr. Behera, Dr. Lisa, Dr. Vijayanand Reddy, sir, and to the speakers, Dr. Solange, Dr. Tilak, Dr. Navneet Singh, for this wonderful session. Now we are moving to our next session. And I would like to invite the chairpersons, Dr. Pankaj Shah, sir, who is Vice President of Gujarat Cancer Society, and Sadvichar Parivar, Ahmedabad, and Dr. Shoaib Zaidi, who is Senior Consultant Surgical Oncologist from Indraprastha Apollo Hospital, Delhi, to proceed with the next session. Over to you, chairpersons. I request Dr. Pankaj Shah, sir, to invite our next speaker, Professor Tony Mock.
Thank you, everyone, and thank you, Shruti and the team, for inviting me for this particular important meeting. We have heard the immunotherapy of lung cancer, and now it is a time to listen about the various TKIs in the lung cancer. And our speaker is Professor Tony Mock, from Chairman, Department of Clinical Oncology, Chinese University of Hong Kong, Hong Kong. May I request Dr. Tony Mok to present his talk.
Hello, I'm Professor Tony Mok from the Chinese University of Hong Kong. Thank you for the opportunity to ask me to talk about this important question: is the resistant third generation TKI fueling a new therapeutic strategies? Now, so first of all, this is my disclosure, and more specifically, I'm on the board of director of these three companies. Any question you ask me, just like, would you marry me? Or any other question is yes, no, or maybe. However, to answer this question is very simple. Definitely, it's not a no. It's either a yes or a maybe. So I'm going to go through some of the biology and the strategy to answer this question. First of all, we have to understand the biology of the strategy, and then subsequently focusing on the targeted therapy strategy, the ADC strategy, and the immunotherapy strategy after failing osimertinib or other third generation drug. First, about the biology. Now, the biology of resistance is complex. I'm trying to summarize the essence of it. Now, despite of what drug you give, when EGFR first presents itself, it's not just a single EGFR mutation. Now, this is a study by Frampton Cancer Discovery from Foundation Medicine, over 4,000 cases. The patient with the EGFR mutation, as you can see, also had a number of co-mutation in the beginning. That may include TP53, which is the most common one. But other than that, you can have a whole arena of different mutation, including ALDA1A and also the CTK. So how much impact of this co-mutation is not certain, but then there are some prognostication factor of each of this mutation. And also, we know that once you put the drug EGFR mutation possible cancer in stress, there will be having different kind of response in terms of the subsequent mutation. Now, this is the data from Singapore indicating about close to 20 cases of patient with EGFR mutation. As you can see, the trunk mutation is consistent, but then the branch mutation of this EGFR can be quite diverse. So in other words, it will be hard to predict what may happen once you put the stress on the EGFR trunk mutation. So we'll predict it to be a very heterogeneous in terms of outcome as well. So for that, is actually come into some of the data that we have. The data has come from the plasma-based test by Guardant 360 on the patient who have first line or second line osimertinib, namely the plasma sample from the FORA study and the plasma sample from the AURA study. So as you can see, consistent theme is that you have the C797S, and also you may have a HER2 amplification and a MET amplification. The rest is a little bit heterogeneous, and then a large proportion unknown. Why unknown? Well, we have to understand that we are actually using Guardant 360, which only have about 71 genes. So in other words, there can be a lot of so-called cancer that's not covered. But one other important point is that patients who are second line osimertinib, meaning they are start off with T790M positive, about 50% of them will lose the T790M as one major mechanism of resistance. So putting that in mind, I think one conclusion is that we get multiple resistance mechanisms. Therefore, we need multiple strategy. It's unlikely that we have one strategy to cover everything. So on the multiple strategy, let's take a look at the whole picture. Now, this is a simplified picture from Cancer Discovery. And you can see that it can be a resistance mechanism in the EGFR, which is the C797S, or it can be in the MET pathway, which we already talked about briefly. And then HER2 has also covered it. But then there's also the EMT transformation, meaning that transformation to small cell lung cancer. So those are the mechanisms that we'll talk about today. And then also that we can potentially target a apoptotic pathway, but right now we don't have a very good apoptotic drug, like the BEAM2 is actually important on the apoptotic pathway. But overall, we also have to cover the ADC and the immunotherapy. So that is the basic scheme of our discussion. Now, targeted therapy, what is the strategy? Well, the first is a strategy against the C797S. Now, we have to understand that the C797S is the binding site of osimertinib. So once it got so-called mutated from C to S, then it becomes a resistant or not non-binding to osimertinib. But in order to tackle that, we have to be very careful because some of this patient also have the T790M mutation in the same time, which prevent you from binding a T790M site. So we end up that we require something called the aerostatic compound. So this is actually the first paper come from Dana-Farber that indication of a aerostatic compound potentially that can inhibit a patient with C7IFNS. Moving forward, there is one of the first data that has come out subsequently on aerostatic compound. It's called a compound 40125 by JPJ. And then you can see that it is an anchor on one side and then inhibiting back to the pocket. And however, this has to be in combination with osimertinib for the proper inhibition of the tumor. So this is actually data that was from 2019, but up to this day, we have not any solid data on its clinical efficacy yet. On the other hand, Blue 947 is a compound as such targeting the T790M and C797S. And for that, you can see this compound can actually on the cell line and it had a reasonable IC50. And right now, this drug is actually ongoing as a clinical trial. Now, the other strategy is to inhibit the EGFR and MEK in the same time, and that is the bi-specific antibody, immunotherapy. You probably know a lot about it already. And so the early data is relatively encouraging from the Chrysalis study, phase 1. And on the patient who failed that osimertinib is a combination of amivantamab together with lasatinib, a third-generation TKI from Korea. And we're looking at tumor response rate. It turned out to be 36%. Reasonable response rate in a small population, but the progression-free survival about 4.9 months. But most of these patients had multiple previous line of therapy. So early data, not quite ready for so-called the major treatment yet, but then it is one strategy that should be developed further. Now, the next question is that whether we can really utilize the biomarker. So they had a very small subgroup of 10 patients with IHC overexpression of either EGFR or the MEK, and for that, out of that, 9 out of 10 patients had responded. But again, small population, whether that will be the future biomarker, certainly to be validated. But one very important strategy on the MEK inhibition. Now, for that is another way inhibited is by tyrosine kinase, and for that we already got comatinib and tepotinib, which is a potent type 2 MEK inhibitor that is actually approved for MEK exon skipping. But what is its application in a MEK amplification post-EGFR TKI failure, such as osimertinib? So the data actually come from the Tatton study from this year's WCLC. Han reported that fact that the patient who failed the osimertinib and then with MEK amplification defined it as either FISH copy number over 5 or the MEK 7 over 2, IHC 2+ or 3+ or NGS positive. The 4 cohort is either prior EGFR failure with the osimertinib or first and second generation TKI failure but T7M negative, or first second generation failure but then T7M positive. Cohort D is same as part B2 except that they give a low dose of sunitinib, which is related to toxicity. So for that, the response rate is actually for osimertinib failure group is actually impressive, about 33%. And that is a patient who failed osimertinib go on to receive a savolitinib, which is a MEK inhibitor together with osimertinib. They still got 1/3 of the patient responding. But on the other hand, if the patient are actually first and second failure, but then T7M negative, they're still able to induce a response of about 60%. And that is actually translated to a certain degree of improvement in the progression-free survival. But this needs to be validated in a randomized phase 2 study, which actually will roll out sometime this year. Now, based on that, let's go on the next strategy, which is small cell transformation. The data on the small cell transformation is scanty, but this is one of the best papers we can get from 2019, 58 patients with small cell transformation. At the time to transformation, about 18 months, but most of them, almost all of them have TP53 and RB1 loss. But the response rate is initially quite reasonable, 54%, but the median progression-free survival is short, only 3.4 months, and overall survival is only 10.9 months. So relatively disappointing data. So once you get transformed, the prognosis is poor. So the question is that the strategy would be, can we really prevent it from transforming? So for that, there's one ongoing clinical trial right now in Memorial Sloan Kettering by Helena Yu. Is a patient who are EGFR mutation positive, but in the same time, RB1 loss and P53 positive. And then the patient may have the TKI started or the treatment naive within 6 weeks. then they were able to get combination of osimertinib together with standard chemotherapy or etoposide and platinum. So that's the question, is to give the chemotherapy early so where they can prevent the transformation if the patient is RB1 lost and P53. So that's one strategy for small cell transformation. Now, after this targeting the EGFR, MEK, and also the small cell transformation, let's talk about ADC in general. The concept is important. In a way, it's a monoclonal antibody targeting the cancer cell with a specific antigen against. And then you use a linker to link on a cytotoxic drug, a very potent one. Usually is Dustatucan is one of the topoisomerase inhibitor. And then this linker is actually, released it, or actually resolved it once in endosome, and then released the cytotoxic drug to kill cell. It sounds like perfect system, but of course, nothing is perfect. But let's take a look at the potential efficacy. The major development now of ADC is the fact that one molecule can have multiple cytotoxic drugs, meaning that the linker ratio is actually higher, meaning that they can carry more cytotoxic drug with it. So this is the list. If you're focusing on the lung cancer in the HER2, we have the TDM1, which is a long time ago, and then the new one, trastuzumab deruxtecan, while ADS8201 is actually recently approved for breast cancer as well. And then there's a HER3, the U31402, and there is a CMAC1, and then also there is a TROP2 one. So basically, the three sites that ADC may target is the HER2, HER3, and MEK, and actually TROP2. Now, let's look at the data. With the U31402, which is anti-HER3, now almost all EGFR mutation positive cancer patients will have an overexpression of HER3. So that makes sense for it to be a recent target. And then the data was actually reported in Cancer Discovery by Poseidon, first released it in ASCO, subsequent in Cancer Discovery, reporting a response rate of about 39%, and then median progression-free survival 8.2 months. So it is early data, but still that is a very suggestive data. And so this drug is actually moving on into randomized study right now. So the likelihood is the fact that whether it's going to be treatment naive post-osimertinib or post-osimertinib and then post-chemo, and then so this type, either of this randomized study likely will roll out sometime this year as well. So this will help us to define what is the best timing to consider the ADC in the osimertinib failure. Now, this one is on the HER2, but then mostly it is on HER2 mutation. Now, breast cancer is HER2 amplification. In lung cancer, post-osimertinib, we may also have HER2 amplification. But the data we see a 55% response rate with the trastuzumab deruxtecan is on the HER2 mutation, and then with the progression-free survival about 8.2 months. Those are attractive, but its approval for HER2 is on the way, but its application in HER2 expression is still pending to be defined. There is a small subgroup study from this one, and response rate is about 24% reported by Apikawa the year before. Now, so with this in mind, I think that we have to wait for more data before we can decide. What about the so-called ADC on MEK? Now, ADC on MEK, this is data come from Ross Cambridge from WLC this year. Trastuzumab vedotin, and then they look into the MEK amplified patient, but then I'm not quite sure the definition from this abstract. And you can see that they got a group of a patient that is EGFR wild type and a group of patient that is EGFR mutant, 60 in each group. And there's high and intermediate in either group. Now, to cut the story short, for patient without the mutation that are MEK high, the response rate is actually reasonable at about the 35%. But then for the EGFR mutant, the response rate for the MEK high is only 13%. But to remind you, the patients who are mutant, they actually have multiple line of therapy, and then they have chemotherapy just beforehand. 84% of them had chemotherapy. So I think this is the early data. I will not give up entirely yet, but the early data of 13% response rate is not very supportive of this direction for EGFR mutant. Now, another was TROP2. TROP2 is in respect of the EGFR mutation status. It may occur in a lot of different types of cancer, including lung cancer. And then the so-called the TROP2 expression is independent of the EGFR status. And this is a glycoprotein that's common across all cancer. Now, for triple negative breast cancer, Trodelvy had already been demonstrated response rate 31% and are already approved for breast cancer. And median progression-free survival is about 5.6 months. So exciting data. But for lung cancer, it is still early, and there's still only phase 1 data that's being available. On EGFR mutation positive, I think we still have to wait and see. Now, last but not the least is immunotherapy. One thing we must be aware that TME status, the tumor microenvironment status of the EGFR mutation, is different from other cancer. The tumor microenvironment is created by a tumor for the purpose actually to protect the cancer, because the cancer itself, one environment that they're comfortable to grow in. So the player may include the lymphocyte, the myelocyte, the cytokine, the fibroblast, and also the multiple of the exosome. And all this environment is that, have the purpose of to promote cancer growth and also to defend against the immune cell. So, and especially in EGFR mutation positive lung cancer, it's quite well known that the environment is actually quite resistant to the PD-L1. So how, may it affect it? This is a good summary. There's a few aspects of the EGFR that is actually special. So first of all, is the fact that there is a CD73 and adenosine, which is usually upregulated in EGFR mutation positive. And adenosine is the one substance that may potentially inhibit the myeloid cell from activity. The T regulatory cell is also an important part of the whole picture, and the EGFR mutation is actually a reduction of the T cell degradation. And also EGFR may potentially affect the PD-L1 expression, usually reduce the PD-L1 expression. So all this putting together, making EGFR mutation probably a poor response to immunotherapy. That is a hypothesis based on science and based on biology. But then when you look into the clinical data, this is a report from Julian Mazzazier on the multiple different type of patient with the driver oncogene, and EGFR mutation, the response rate in the second-line situation is only about 12%. And that is actually related to a progressive data in the subgroup of the randomized study, like the Checkmate 017, 057, and the OAK study, and also the POPPER study. All this includes a small percentage of the EGFR mutation population. And you can see the consistent response rate about 10 to 15%, and the median progression-free survival about 3 to 4 months. So overall, it's quite well established as a single agent, either retrospective study or prospective study, that we do not expect a good outcome. So once you talk about the microenvironment, there are multiple factors in play. And one that we can actually contribute is actually angiogenesis. As you can see, the VEGFR contribute to a number of so-called the mechanism in terms of the microenvironment. So potentially target VEGFR may facilitate and change the tumor microenvironment for the immunotherapy. So this is first observed in IMPA 150, as you probably know, is Taxol, Carbo, bevacizumab, and tislelizumab. And then in this particular study, 10% of patients are EGFR mutation positive. So for that subgroup, there is a high response rate, about 71%. And when you compare the 4 drugs with the Taxol, Carbo, and bevacizumab, there's improvement in progression-free survival and overall survival. As compared to 3 drugs, only the Taxol, Carbo together with atezo compared with Taxol, Carbo with the bevacizumab, there's no such advantage. So look like there is a so-called improvement when you give bevacizumab together with a PD-L1 inhibitor. Now, we need further data. And so there's one additional study this year, last year, is the Orient 31. That's come from China, EGFR mutation positive patient who failed the TKI. Looking at the patient that are actually received 4 drugs, which means that patient actually received the cetuximab, which is a anti-PD-L1, as also the a biosimilar bevacizumab, and compared to the Taxol, Carbo alone. And for that, you can see that there's improvement progression-free survival, 6.9 versus 4.3, and improvement in response rate. So, and additional study from China showing the same phenomenon with the Forte regimen. It will be first substantiated by IMPA 151, which also being done in China. 50% of this population will be EGFR mutation positive. Another one is to target the adenosine inhibition. You can either target the receptor or the CD73 by a drug called anucumab. Now, based on a study called co-study that come out just this year on stage 3 disease, durvalumab alone as a maintainer Pacific versus durvalumab plus oleclumab versus another immune inhibitor, we're able to see a higher response rate as well as an improvement progression-free survival. Now, these are not EGFR mutation positive patients, but just demonstrate that potential combination of a PD-L1 and an anti-CD73 may improve the treatment outcome. So I think it will be interesting to look for those data in EGFR mutation population. So coming back to the question, well, yes or maybe, that's definitely, it is a yes. So I think that we should move on, and then to summarize the fact that we have the biology to demonstrate why osimertinib had failure, and then we targeted, including strategy on C797S, MEK, and small cell transformation. ADC, we can anti-HER3, HER2, MEK, or the TROP2. And then immunotherapy, I think we probably have to work on the tumor microenvironment, that's our strategy. And anti-VEGF in combination have demonstrated potential efficacy. And then they have been supported IMPA 150 subgroup analysis and Orient 031 data. And in the future, I think adenosine and anti-CD73 will hold high hope for the situation. That is actually all for today. But then one other strategy that I can share with you in the future is that when we go to buffet, what's the best way to have the best food? Thank you so much for your time. Thank you.
Thank you so much, Dr. Tony Mock, for this wonderful talk. Now I request our chairperson, Dr. Shoaib Zaidi, to invite our next speaker, Dr. Natasha Lee. Over to you, Dr. Shoaib.
Good evening. Thank you for inviting me for this conference. So the next talk is by Dr. Natasha Lee. Dr. Natasha is a professor of medical oncology, University of Toronto, Princess Margaret Cancer Center. So may I invite Dr. Natasha for a talk on novel oncogenic drivers.
Hi there, my name's Natasha Lale from the Princess Margaret Cancer Center, and I'm delighted to talk about the evolving landscape of oncogenic drivers in lung cancer. These are my disclosures. At a very high level, I'm going to go over some of the more recent targets and therapies beyond EGFR, ALK, ROS1, and BRAF, highlight some of the practical challenges in implementing precision medicine in the clinic, and talk about a few selected future strategies. I'm going to start with a case. This is a 62-year-old lady that I met last year during the pandemic. She was a Caucasian, never smoker, and was being investigated for recurrent pneumonias that didn't clear. She had a family history of breast and kidney cancer, and when she was finally diagnosed, had widespread disease, had a biopsy to rule out breast cancer, is what the outside pathologist was told to do, and he diagnosed adenocarcinoma from the lung, but interestingly also did breast markers, including HER2, and showed HER2 positive expression. Clearly for lung cancer, we need to know more, PD-L1, and a growing list of genomic targets with changing questions of which targets to test, which tests to use, and when to introduce testing. Current recommendations are rapidly growing. On the left, you can see that the NCCN currently recommends at least 8 genomic targets, as well as PD-L1. The other organizations are also moving up to that, and I think it's really just a reflection of how recently they've updated their guidelines. ESMO currently recommends NGS testing for all advanced adenocarcinoma patients, and of course, this is moving even to earlier stage, for example, with EGFR testing in patients with resected lung cancer for adjuvant TKI therapy, as well as PD-L1. I think it's so important to remember that complete biomarker testing does not stop with PD-L1, but also importantly, genomic data. We know that 1/4 of our patients with genomic targets have high PD-L1 expression and are candidates for targeted therapy, which will outperform chemo immunotherapy or immunotherapy alone. But unfortunately, not all patients can access NGS. There's a nice paper, as you know, many of you are authors and collaborators on this, talking about or illustrating that certainly in India, patients that access genomic testing because of funding reasons will often access a variety of tests, most commonly immunohistochemistry and PCR-based testing, and that NGS is uncommon. However, if it can be offered routinely, the results, I think, will surprise you. We put together a project last year where we actually had an industry-funded reflex NGS testing program just to see how valuable it was, and we actually found targetable alterations in half of our patients with lung adenocarcinoma. Some of the barriers, of course, cost, quality of both assays, lab experience, and tissue. The fact that tissue testing is not centralized, and the fact that those people who make the diagnosis of lung cancer often don't know which molecular tests are required. Turnaround time and sufficiency of tissue are, of course, also major barriers, particularly in Europe and US and Canada. But clearly we need to keep pace with the very exciting explosion in targeted therapy options. And we can see for that the 8 recommended biomarkers here, there are targeted therapies now approved, at least in the US and growing around the world for each of these genomic subgroups. When you look at the placement of these, all of these have been approved based on single-arm, non-randomized trials. Many of these in the US are approved first line, usually if they have response rates above 60%. Tepotinib is a little bit lower at 43%. Many of these drugs, for example, targeting TRAC, RET, and NET, have very impressive intracranial activity. But drugs developed in the second line with lower response rates as single agents, sotorasib, amivantamab, mobocertinib, as you can see here, these really require platinum retreatment. One of the questions always is, when patients have oncogene addiction or have an oncogenic driver identified, how helpful is immunotherapy as part of their treatment paradigm? And I think, as you can see on the right, for many of these patients with oncogenic targets, immunotherapy is a very limited benefit. And perhaps the exceptions to this are patients with KRAS G12C or other KRAS alterations, and those with MET exon 14 skip mutations and perhaps other MET alterations. We're learning also that co-alterations may be relevant. They're probably not relevant for practice just yet, but we've learned a lot about potential negative prognostic associations with STK11 and KEAP1 alterations concurrent with KRAS. There have been some exciting data looking at sotorasib on the left and adagrasib on the right, suggesting that in patients with STK11 co-mutations, perhaps the G12C inhibitor may lead to better outcomes. And perhaps this is a strategy to get to first line or in combination with other agents. So what about our patient? Well, she did have genotyping. She had a hotspot panel, so not broad spectrum NGS, and she was found to have an exon 20 insertion mutation. Also, she had a liquid biopsy, again, a very limited DNA hotspot panel, and was found to have a MET variant with a high variant allelic fraction, 53%. And in the fine print at the bottom, the report talks about the possibility of a germline variant, and she had PD-L1 negative disease, as you might expect. So are they both actionable? Which one should we treat? Should we go for the higher VAF or the one that we better understand in lung cancer? Does she need further testing? What should we do about this comment about the germline? Lots of questions for a Monday morning in clinic. So, there are a number of resources that you can use in clinic that are very helpful. Sometimes they'll be on the report with very excellent annotation, but sometimes I'll turn to OncoKB or other sources to see that she has a classic exon 20 insertion mutation, which is actionable, and that her MET alteration certainly confers sensitivity to MET inhibitors, but it's not a MET exon 14 skip alteration, and there is some concern about the level of evidence supporting targeted therapy. So the current standard, of course, is platinum-based chemotherapy. PD-1 inhibitors should not be used as single agents in the first-line setting. And the NCCN also cautions that if you use chemoimmunotherapy, you do need to be mindful of subsequent toxicity later. They mentioned pneumonitis, but we've also learned that hepatitis is potentially very important. We have 2 exciting new drugs, amivantamab, which is intravenous, a nice response rate of 40%, duration of response of about 11 months, but a very intensive intravenous schedule. weekly to start for a month, and then every 2 weeks. And also mobocertinib, easier for patients. Oral is associated with significant diarrhea, 28% response rate, but the potential for response may be prolonged. The median duration of response in the data reported so far, 17.5 months. We've also learned that NGS testing is important. On the right, in the bottom right, you can see that common PCR-based assays only detect about half of the potential exon 20 insertions that lung cancer patients have. And so potentially we're missing half the patients with PCR. Now, what about her HER2 expression? And I think it's so important to recall that HER2 is different in different cancers. So in breast cancer and gastric cancer, HER2 amplification is quite common. We do see it in lung cancer, about 3%. We also see HER2 expression. We see it perhaps more commonly after EGFR kinase inhibitor resistance. But what we're really interested in are patients with exon 20 insertion mutations. We see those in about 2 to 4% of cases, never smokers, women, patients of Asian background. And in particular, it's the YVMA insertions that you can see on the right that are the most common. A small number of patients have mutations in the transmembrane domain, and those are classically associated with response to kinase inhibitors like afatinib. It's also important to remember that just because one of these markers is positive does not mean that the others will be, and there's only about 10% of overlap between ERB2 amplification and exon 20 insertion mutations. A very nice publication in the New England Journal recently from Dr. Bob Lee and colleagues, looking at the trastuzumab deruxtecan antibody drug conjugate. This is also, of course, approved and well known to you in breast cancer, but in lung cancer, they use a slightly higher dose, 6.4 milligrams per kilogram instead of 5.4. Very nice response rate, 55%. Nice median duration of response, 9.3 months, and progression-free survival as well. The challenge, of course, really related to the deruxtecan moiety and perhaps the dose is the number of patients that stopped for toxicity. 1 in 4, a third had dose reductions, a quarter had interstitial lung disease or pneumonitis related to drug, a few of them fatal, and while half of patients recovered with steroids, the other half have not yet. And you can see here on the right a very nice waterfall plot that really does seem to track with the insertion mutation, and whether or not HER2 protein is expressed or whether or not it's amplified seems less relevant. There's also activity in patients with CNS disease and with prior HER2 therapy. So this is a highly promising agent, but is it too toxic first line in our patients with lung cancer? Should we be looking at the breast cancer dose, 5.4 milligrams per kilogram? Those studies are ongoing. And is 55% enough for first line without a randomized trial, or do we need to add a drug like platinum? I think it's also important to remember in clinic that IHC testing, like our patient had, is not the same as mutation testing. When we look at just IHC expression, the response rates are much lower and in fact aren't controlled for the possibility that this low number of patients who did respond may well actually also have HER2 insertion mutations. So important to remember that for drugs like this, it's really the mutation that you want to watch for. There are also some nice data presented at ESMO looking at Poseidon. This drug does have toxicity. Response rate's a little bit lower at 44%, but still excellent. Median duration of response, 5 months, but it is an oral agent. Does have significant toxicity, including diarrhea, rash, and stomatitis, but these are reversible, and exploration of BID dosing is ongoing. So my patient came to me and said she was not interested in platinum doublet therapy, which would have been the first line standard. And so we put her on a clinical trial. She's actually had a very nice response, as you can see on the right. We did go back at the time. We didn't wait for repeating tissue testing, but we did do MET testing in tissue because we thought that the alteration in blood with such a high VAF would be a normal variant in her germline, or sorry, not a normal variant, but a variant in her germline. And we also went back to look at ERBB2 testing, and this was negative. We then sent her to the genetics clinic, and I think this really highlights the importance of molecular tumor boards, the ability to access genetics expertise. You know, certainly if you're practicing in isolation or you don't have a group with an organized tumor board, there are things like the Foundation Medicine Tumor Board or other tumor boards that you can join. I know Sloan Kettering has a tumor board that you can join. Also, David Gandera and the ISLC have tumor boards that you can join. But again, it's so important that no matter which one you join, you do have access so that you can review your challenging cases. And these are some of the resources that I use to help me determine what the clinical relevance is for my patient. In particular, OncoKB is one of my go-to databases now. And also when you think about when should you be concerned about germline alterations, usually there's a very nice paper from the ESMO Precision Medicine Working Group, but usually, you don't need to worry about this until you start to see sort of variant fractions or more than 30% in terms of single nucleotide variants, or more than 20% for small insertions and deletions. Although again, if you have a very highly cellular sample, that might be related to cellularity as well. So what about resistance? And, it's been interesting across the genomic subtypes and across the different targeted therapies, the pattern of resistance is very similar. You have on-target mutations, so an alteration within the drug target. You have bypass signaling or emergent amplification, commonly met across many of these groups, or other fusions. Mutations in downstream effectors, for example, MEK, RAS, or others. And histologic transformation or lineage plasticity, small cells seen now beyond EGFR and ALK and ROS1, and also a transformation to squamous and other subtypes. And, there are a lot of data out there. I'm just going to give you a few examples. Already gatekeeper mutations and solvent front mutations. Gatekeeper mutations, of course, very relevant to ATP binding, and solvent front really relevant to the steric hindrance that's presented to drugs. But you can see here on the left with larotrectinib, they've identified solvent front mutations that can be overcome by newer agents, selotrectinib, repotrectinib. And on the right for RET, again, both solvent front and gatekeeper alterations that can be overcome by both emerging and existing drugs, cabozantinib, vandetanib, ponatinib, and more. But it won't be easy for all of our targets and targeted therapies. For example, with KRAS G12C inhibitors, because it's not a receptor tyrosine kinase inhibitor, rather it binds to GDP bound or inactive KRAS, we really don't necessarily have the same mechanisms of resistance. Interestingly, they can be classified that way. So acquired alterations in KRAS, other bypass signaling. We've seen acquired gene fusions in colon cancer, although not lung cancer, although it is small numbers. But in particular, you can see the emergence of escape through different signaling pathways, upstream ability to evade this conversion to drug-bound inactivated GDP-bound RAS. And of course, things like concomitant alterations, the immune microenvironment, and allelic frequency, as well as KRAS dependency. Is it a clonal event or a subclonal event? So does it drive the cancer or is it more of a passenger? I think are all going to be important. Now, clearly, we have so much trouble getting our patients biopsied in the first place and getting testing on tissue that this is going to be very challenging on an ongoing basis. And so liquid biopsies have really emerged as a potential solution. Certainly in the first line setting, whether we use it sequentially if insufficient tissue at the same time or use plasma first, this has really become a robust and acceptable way to detect alterations. We recently did a study in Canada where we looked at testing patients both with tissue and blood, and we found on the left that more patients were able to access targeted tissue, targeted therapy when we combined these. Patients had similar outcomes, whether we found the target in tissue or in plasma. And in the Canadian system, which is of course a relatively high resource system, we actually saved money, because immunotherapy, which doesn't work in these patients, is more expensive than targeted therapy. So we were able to get more patients to more effective, less expensive treatment. Plasma testing was also faster and rescued more patients. And what about monitoring? And so you can see over time, clonal evolution and different changes. And certainly the temptation in oncology is always to add more drugs and to add more targeted therapies. But could it be that we could also de-escalate if a patient has had 1 year of checkpoint inhibitor maintenance therapy? Could we check ctDNA levels to discontinue something, or could we add chemotherapy or radiotherapy, not just targeted therapy? And I think this is certainly going to be an important way forward, and we're going to need trials to demonstrate clinical utility. So to conclude, in 2022, I think we've never seen a faster pace of evolution of precision medicine in lung cancer. That balancing act in both low and middle income, and I must say even in high income countries, continues to be a struggle as we try to achieve best practice, for example, reflex NGS testing and access to targeted therapy for all patients versus best possible practice. Obviously, you're not going to ask a patient to spend money on NGS if you know they can't afford targeted therapies or you can't get them, and cost is always a challenge. I think, though, it will get more challenging, so we do need to find ways to overcome our issues with access. There's going to be more precision and more profiling in our future, whether it's identifying better targets for existing therapies, such as co-mutations, antibody drug conjugates, more targets, for example, in PARP, ATR, and others, and moving earlier in the course of disease. Finally, I think that we will see more plasma NGS-guided treatment decision-making, particularly in the targeted therapy realm. And so we see a lot of progress ahead. And with that, I want to say thank you so much.
Thank you so much, Dr. Natasha Lee, for this wonderful talk. Now I request Dr. Pankaj Shah, sir, to invite our next speaker, Dr. Kumar Prabhash.
Thank you, Rekha. For Dr. Kumar, lung cancer in India, he is the champion of the lung cancer in India. He has studied it in deep and has presented lots of his own observation and research in the field in the Indian patient. And it will be, before we go for the two panel later on, it is now right time to listen to Dr. Kumar about the Indian patient perspective, how they are doing on the EGFR and ALK mutation. Dr. Kumar.
Good evening, everyone, and thank you. Thank you, everyone. And at the outset, let me thank the organizing secretary for this opportunity, and thanking Dr. Pankaj Shah, sir, for the kind introduction, sir. And my topic for today is EGFR and ALK mutation in lung cancer and outcome in Indian patients. And I'll try to show that what is happening in Indian context. Maybe not as exciting as some of the lectures we heard, but hopefully sobering and reassuring. Starting with the molecular profiling, this is the data from Indian context, adenocarcinoma. This is the kind of mutations what we get, maybe similar, but different proportions. This is the squamous cell data, and this is a bit striking, and it is important because it helps in our clinic. And what we did observe that good number of our patients, they do have EGFR activating mutations where we can work upon it. And it will be good to see that in NCCN guideline also, it is getting reflected that there is an acknowledgement that in squamous cell carcinoma, you do have mutations which can be targeted, including EGFR mutations. Coming to EGFR mutation per se, this is the incidence rate with around 1,000 odd patients, what we had, that was around 23%. Looks like it has stayed true. And this is in 9,000 odd sample, similar number of patients getting EGFR mutation in our population. Coming to the outcome, one of our first study, which we compared the targeted therapy to chemotherapy. And what we found that in our population also, this is the updated data. The disease control is better with targeted therapy, that is gefitinib, as compared to pemetrexed carboplatinum. And this is the updated overall survival data, suggesting that overall survival is similar in both arms, and that's primarily because there's a whole lot of crossover which happens from chemotherapy to targeted therapy and vice versa. We also did analyze data for squamous cell carcinoma patient with EGFR mutation, and what I can conclude, the most important factor in these patients remains they are able to take TKI or not. It is important that in squamous cell carcinoma patient also, if you have EGFR mutation positivity, then one needs to give TKI to these patients to improve the outcome. We do encounter many uncommon mutations. This number is going to increase. These are the initial experience of the uncommon mutations in EGFR mutation positive patients, and what we can say that they are not all the same, and the outcome varies from the median survival of around 2 months to 22 months. So we will be able to decipher this as the time goes by for these uncommon mutations, and we'll have more and more of them being sensitive where we can use the TKI, and many more of them which are not so sensitive, which we will require some other treatment or not to give TKI. can we get better? And this was our own work, which we combined geftinib plus chemotherapy as compared to geftinib. And this was the trial design where these EGFR mutation positive patients with palliative intent treatment were randomized between TKI to TKI plus chemotherapy. These were 350 odd patients which were randomized, which suggested that if you combine it, then you do have a better control of disease and also better survival. And right now we do also have the updated data. And what we can see that in our population also, you have significant proportion of patients who do survive beyond 4 years, 5 years and beyond. And the survival advantage to this combination remains. The median survival improves from 19 months to 28 months in these patients, highlighting that this happened during the time where we do had a COVID issues where the chemotherapy administration became a challenge in these patients. But it appears that adding the chemotherapy in these patients, the advantage for adding the life to the patient remains. We see the options of the first line treatment in these patients and leaving the initial, the TKI, which we think they may be relatively inferior in controlling the disease. In the other 5 options, the option of combining chemotherapy to TKI is most affording to our population, especially in the situation where we want that these patients have better survival as compared to giving only older TKIs. Coming to ALK positive patients, this is the ALK positivity in our population. The recent data with 5,000 plus patients, it appears the positivity rate is around 10%, and it appears that it remains sustained, suggesting that we may have a higher positivity as compared to what we have seen in the Western world. Coming to outcome of these patients of ALK positive patients in our population, primarily where we use crizotinib and ceritinib. These were the initial publication, and now this data is for 400 plus patients, that is 441 exactly. We were able to give the first line TKI in 65.8% of the patients, and overall 80% of the patients received TKI sometime during the treatment, and highlighting the issues why we were not able to take it, and also highlighting that if you put effort, then if you involve the NGOs, then you are able to provide treatment to majority of the patients in this setting with some one of the TKIs. Coming to outcome of these patients, if we take the progression-free survival, this was 17 months with the first generation TKI, what was given to these patients, that is crizotinib and ceritinib, as compared to the patient where we were not able to give TKI in the first line setting. This is, remember, out of this 149 patients, there were patients who received TKI in second line setting. Coming to overall survival, in overall group of these patients, that was around 30 months odd. As we had a group of patients who never received TKI, because I suggested that we tried our best to get TKI for these patients, but that also gave us a chance to compare these patients who received TKI versus who didn't receive TKI, and it appears giving TKI adds life to the patient, and the median survival was around 32.8 months as compared to around 12 months in these patients. We also analyzed the data for poor performance status patients because we had a significant proportion of patients who were poor performance status, and we tried to analyze this poor performance status patient who took TKI and who didn't take TKI, and it appears in these population also giving TKI adds life to the patient. As we had some decent number, so we could decipher between the PS performance status 2 patient as compared to performance status 3 and 4. And it appears that performance status 2 patients do better than performance status 3 and 4. And these performance status 3 and 4 patients, where we expect the median survival of around 3 to 4 months, we could get the median survival of around 8.6 months if this TKI is given. And you do have some proportion of patients who survive beyond 2 years in this population. Overall survival, as far as the brain mets is concerned, it appears that giving them first and second generation TKI, where majority of the patient did receive radiotherapy, there is no difference in the outcome. Coming to long-term outcome, we tried to analyze the data for the patients who had minimum 4-year follow-up after their last treatment, which has been given when the treatment was started to them, and it appears that the 5-year survival in these patients is around 40%, which is encouraging. We did have some patients who received lorlatinib. This was the initial data which we did analyze, and it appears in this setting in our population the progression-free survival is around 16 months and with median OS of around 21 months in this population. We had a chance of, because having this mutation profiling, having coexistence of mutations like EGFR and KRAS, and it appears in this situation giving TKI is meaningful, but I'm not sure what will happen once we have a KRAS inhibitor available in this population. We also had the data for having EGFR and ALK mutation positive patients, which we had around 24 of them. This were the population which were positive by IHC in all, and one positive by FISH for ALK. And all the patients were positive for EGFR mutation by RT-PCR. And what we see here, that one of the most important factor remains that were we able to expose them to TKI or not, and most important, looks like exposure to ALK inhibitor becomes most important factor, suggesting that exposure to TKI is important. And it appears the patient who are exposed to ALK TKI, they do far better. I can't say conclusively, but looks we need to expose these patients to both TKI. Is giving concurrent TKI useful? I can't say for sure, not conclusively. We did have a few patients where we have given it, but can't say for sure with the data which is available that giving concurrent is useful as far as the outcome is concerned. But it is true that it is safe to give them concurrently. So in conclusion, there have been significant development in management of lung cancer for EGFR and ALK mutation. Targeted therapy has significantly improved the outcome. It is important that we develop the diagnostic tests and also the treatment protocol at local level if you want to have a better outcome of these patients. And not to forget, the tobacco remains the most important preventable cause, and we need to focus on that. These are the acknowledgements for my students and my colleague working with us in the lab, and my colleague who works, what we have seen the lab data primarily is from Dr. Amit Dutt and Dr. Anuradha Chowgle, and apart from that, Dr. Vijay Patil, Dr. Amit Joshi, Dr. Vanita Narona, and Dr. Nandini, who is my colleagues who worked on it. This is the lab people who worked, and these are my seniors and my collaborator and the family. Thank you so much.
Thank you, Dr. Prabhash, for this very informative talk. Now I request Dr. Shoaib Zaidi to invite our next speaker, Dr. Lisa Hendricks, for the presentation.
The next presentation is by Dr. Lisa Hendrick. She's a professor of medical oncology in Netherlands. So may I invite Dr. Lisa for her talk on brain metastasis.
Short overview about the past treatments and outcomes of patients with brain metastasis. And then I will focus on systemic therapies and whether they are the future for patients with brain metastasis. And I think first you need to ask yourself some questions before you start systemic therapy. Then I will focus on immunotherapy and targeted therapies. So if you look at the past, the survival of patients with brain metastasis was in general quite poor. If you look at the disease-specific graded prognostic assessment scoring criteria, which consist of age, performance status, the presence of extracranial metastasis, and the number of brain metastasis, then you will see that most of the patients will have a score of below 3, and they will have a median overall survival of only 3 to 6 months. These are all patients treated with radiotherapy from the 1980s to 2007, so quite old data. If you look at the efficacy of chemotherapy versus, so if you look at the median overall survival of patients treated with upfront whole brain radiotherapy or upfront chemotherapy, then you can see that it doesn't matter for the overall survival with which you start, but the median overall survival is less than half a year. But as you know, immunotherapy and targeted therapies really improve the outcome of patients. And you can also see it already reflected in the molecular graded prognostic assessment, which included patients from 2006 to 2014, also treated with radiotherapy. And if you look at the adenocarcinoma patients and EGFR and ALK were incorporated in this, then you see that the patients with a higher molecular GPA score can achieve an overall survival of more than 2 or even 4 years. If you then look at what's in the current guidelines, I summarized the ESMO, ESMO, and the ESCO-ESTRO guidelines. So the ESMO states if you have a patient with no actionable oncogenic driver and asymptomatic or oligosymptomatic brain metastasis, then you can either start with upfront immunotherapy if you have a high PD-L1, or with chemoimmunotherapy if you have a PD-L1 that's below 50. And if you have patients with an actionable oncogenic driver and asymptomatic or oligosymptomatic brain mets. So I was summarizing the guidelines, and I think the ESCO is a little bit more cautious than the ESMO guideline. So for EGFR ALK positive patients and asymptomatic CNS metastasis, they also state that you can give a TKI. But if you have no oncogenic driver, then they say, well, we don't have a real consensus, but pembro chemo is an option. And they don't mention pembro alone for high PD-L1. And I think you also need to understand that the evidence is quite low for most of these recommendations. We performed a systematic review, so we checked the eligibility criteria for patients with brain mets in phase 2 and 3 trials. We included over 250 trials, and if you look at the figure, then you can see that especially for immunotherapy trials, patients had to be treated and stable. Next slide, please. And I think before you start systemic therapy, you need to think of what you want to achieve with your treatment. So I think you want to have local control and freedom from new metastasis. So in the end, you have intracranial control, you want quality of life, but you also need to take into account the extracranial control. So whether you need to start systemic treatment soon. And in the end, you want to improve the survival while maintaining quality of life. Next slide. So you need to think of, does the systemic therapy penetrate the blood-brain barrier? Next slide. The risk of neurological deterioration if you don't have a response of your systemic therapy, but also the toxicity if you start with upfront radiotherapy. Next slide. And indeed, the need for immediate systemic therapy. Next slide, please. So first, I will focus on immunotherapy results. Next slide. And as also was discussed by Professor Peters, brain mets have a different tumor microenvironment. We know that immune cells are present in the brain. We also know that brain mets often have a high TMB, but there is a discordance between tumor PD-L1 expression in the brain and extracranial metastasis. And important, the T-cell clonality in the brain is less, and the brain immune environment is more immune ignorant. Next slide. And there are data mainly derived from monoimmunotherapy or chemoimmunotherapy in patients with treated brain metastasis. And you can see if you compare it with chemotherapy, then patients with and without brain metastasis do derive benefit. But as I stated, most trials excluded untreated or active brain metastasis. And only in the Keynote 189, patients with untreated brain metastasis were allowed, but this subgroup was not separately presented. It's also interesting that in the Empower 150, there seems to be a protective effect of bevacizumab for the development of brain metastasis. Next slide. And we have one immunotherapy brain met specific trial enrolling patients with non-small cell lung cancer. The majority of these patients were PD-L1 positive. They were very selected. They had asymptomatic brain metastasis. Slide back, please. Between the other way, please. Okay, you're moving now the slides ahead while I was 2 slides back. Sorry.
Slide, please.
One back.
Previous slide.
Yeah, thank you. So these patients were asymptomatic, didn't have steroids, and if you can see here that the response rate in the brain mirrored the extracranial response rate, was around 30%, but dissociated responses were noted, and you need to be aware of this. Next slide. And if you look at the real-life data, I think these real-life data quite mirror the data of the phase 2 trial. And especially the patients that are PD-L1 high positive can achieve quite impressive response rates and median overall survival. I think for those with a low PD-L1, monotherapy, immunotherapy is not the way to go. Next slide. We also have data for combination immunotherapy with or without chemotherapy for treated brain metastasis. So the first, the Checkmate 9LA, also discussed by Professor Peters. Brain met subgroup was quite substantial, but all patients had treated brain metastasis. And the intracranial PFS was much longer for the chemo-immuno arm. And also the percentage of patients with new brain metastasis was lower, and the time to new brain metastasis was longer. Next slide. If you look at the Checkmate 227, I think you have more or less the same data, at least for the overall survival, but the intracranial PFS was similar, and the patients in the immunotherapy arm had less brain metastasis, but the time to new brain metastasis was shorter. And with these regimens in treated brain metastasis, you can achieve a 2-year overall survival of 35 to 43%. Next slide. Now we also have phase 2 data for untreated brain metastasis with chemoimmunotherapy, and that's the atezo brain. Chemoimmunotherapy upfront for patients with asymptomatic brain metastasis without an oncogenic driver, and baseline steroids were allowed, and 43% of patients used baseline steroids. Next slide. If you then look at the systemic PFS, then a median PFS was almost 9 months, with a 1.5-year PFS rate of 25%, and important, no new safety signals. And again, a 10% discordant response rate, so you need to follow up these patients also with brain imaging. Next slide. Intracranial PFS was a little bit lower, 7 months, and intracranial PFS rate was only 10%, but the 2-year OS rate was again around 35%. So it is something that's interesting to start upfront with chemoimmuno, but follow the brain. Next slide. And there are quite a lot of trials ongoing with systemic therapy for untreated non-small cell brain metastasis. The most are chemoimmuno or chemoimmuno-immuno. And as already discussed by Professor Peters, I think maybe the chemoimmuno-immuno regimens are the most interesting because the brain tumor microenvironment is different from the extracranial tumor microenvironment. Next slide. But I think that still doesn't answer the question, what's better, whether you need to start with upfront radiotherapy followed by chemoimmunotherapy, or upfront chemoimmunotherapy and then radiotherapy upon progression. But both EDOP and ERTC have protocols in development. Next slide. If we then move on to the targeted therapies, it's important I cannot discuss all TKIs because there is just too much data. Next slide. But if you then look at the oncogenic drivers we have, then you see for baseline incidence, it's around 20 to 40%. It depends on the trial you look at and whether there was baseline brain screening. And I think the cumulative brain mets incidence is really influenced by the TKI you use. If you use a first generation TKI like crizotinib, the blood-brain barrier is really a limiting step. And we don't know whether the biology in the brain mets is really different from the extracranial disease. So it could also influence the brain metastasis incidence. Next slide. If we then look at osimertinib in the FLAURA trial, more than 100 patients with brain metastasis were enrolled, and the CNS response rate was 2/3 for osimertinib versus less than 50% for first generation TKI. Also, the CNS PFS was longer for osimertinib, and less patients developed new brain metastasis. Next slide. If you then look at the T790M patients, then again, osimertinib had a quite impressive response rate of around 2/3, with a mainly impressive median progression-free survival for each of our exon 19 deletions. Next slide.
No, we will reverse the panels.
Sorry? If we then go on to the ALK-positive patients, you can see for alectinib, brigatinib, lorlatinib, and ensartinib, similar data. I couldn't put the same figures for all these different TKIs in, but PFS is longer, intracranial progression-free survival is longer, intracranial response is longer, and if OS data is available, it's also longer for the next generation TKI. Next slide. Then a short summary of other oncogenic drivers. We know that's already been discussed that there are different TKIs or small molecules available. If available, except for crizotinib and ceritinib, the intracranial responses are quite good, but you need to be aware these are very low numbers of patients. And it was not really well taken into account whether these patients had previous radiotherapy or not. And if you can achieve a response with these drugs, if available, the intracranial response is quite long. Next slide. Also, I think an important discussion in these oncogenic drivers is whether we can start with upfront TKI or with radiotherapy. Retrospective series suggest that you can start with CNS penetrating TKI and only use radiotherapy if you have progression in the brain. Next slide. But there are also some discrepant data, again, retrospective series showing that if you have oligometastasis in the brain, then maybe it's better than to start with upfront radiotherapy and then go on to the TKI. Next slide. So for the future, I think if you have local CNS progression, I think we need trials with TKI and concurrent radiotherapy to evaluate the safety and efficacy, and also to prevent a systemic disease flare. We need to evaluate the CNS resistance mechanisms, and I think liquid biopsies of the CSF are very promising. We need to evaluate TKI dose escalation strategies. There is a limited benefit in small prospective series, but we don't know what the plasma levels of these patients were. I think combinations with chemotherapy and anti-angiogenesis are interesting. And for the future, I think the FDA had quite interesting recommendations. We need to document the prior CNS therapies because it really hampers your trial comparisons. We need to stratify for prior therapy. We really need to assess regularly with brain MRI, and we need to follow up these patients. And we need to apply accepted CNS response criteria and define appropriate endpoints. And this guidance document is necessary, as in our systematic review, we showed that these recommendations are not in use yet. Next slide. So my conclusions, I think untreated brain metastases are often excluded from clinical trials, and I think that's not justified. Immunotherapy combinations are effective in subgroups of patients, but you need to be aware that the associated responses are present, and we need to better select patients, and we need to understand the brain tumor microenvironment. And again, I didn't show you the data, but radiotherapy and immunotherapy research is really necessary. We know that CNS penetrating TKI are very effective, and research is needed regarding TKI combined with chemo or anti-angiogenesis and the sequence of radiotherapy and TKI. And we also need to design our trials better and incorporate RANO and FDA guidance. And as these patients live long, we need long-term follow-up. So thank you.
Thank you, Dr. Lisa. Now I request Dr. Pankaj Shah sir to invite our next speaker, Dr. Prabhat Malik.
Thank you, Rekhaben. Now the last speaker of the session is Dr. Prabhat Malik, and he will talk on endpoint in adjuvant trials in immunotherapy and targeted therapy. Dr. Prabhat is from All India Institute of Medical Sciences, Delhi. Dr. Prabhat.
Yeah. Good evening, everyone. Am I audible?
Yes, yes.
Yeah, thank you. So, good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to participate in this prestigious conference. I've been assigned a difficult task to speak about the endpoints in adjuvant trials in immunotherapy and targeted therapy. In fact, when I saw the topic, I thought I'm going to participate in a debate, but fortunately it's not a debate, so I can speak from both the sides, and finally you can decide that which is a better way. So when we look at the clinical trial endpoints, particularly for adjuvant treatment, the commonly used endpoints in various clinical trials are overall survival, disease-free survival, and recurrence-free survival. There are certain more modifications which are used commonly in adjuvant setting, like invasive disease-free survival, metastatic disease-free survival, and so on. I'm not going into details and definitions of these endpoints. But as a clinician, when we decide about the adjuvant treatment, what are the considerations which we need to keep in mind? The first and foremost is certainly the efficacy of the treatment, and the ways to assess the efficacy of a new treatment modality. The gold standard has been overall survival. There have been surrogates for overall survival, which many of the clinical trials have used, are disease-free survival and recurrence-free survival. So that determines how efficacious is the treatment. Next, and the very important aspect, and more so in the adjuvant setting, is quality of life and the patient reported outcomes. On the contrary, in the metastatic disease setting, when we use a toxic treatment, but if it's effective, eventually it reduces the disease-related symptoms, and there can be improved quality of life despite using a toxic treatment. But on the other hand, when you're using an adjuvant treatment modality, the patient is disease-free when you're using the treatment. And if the treatment is toxic and it has to be used for longer duration, there are certainly considerations like quality of life, and we need to be careful about them. Cost is certainly an important factor when we decide about any new treatment modality. And it's even more relevant in this era of targeted therapies and immuno-oncology drugs. There is a risk of over-treatment. When you're in your control arm, not all the patients are going to recur. So if the overall risk of recurrence is low or is a small risk of recurrence, there is a larger proportion of risk of over-treatment, because many of your patients are being unnecessarily treated. The next and important thing which we need to assess whether the relapses in that particular disease settings are salvageable or not. Do we have effective subsequent line of treatment, and how efficacious those treatments which can be used subsequently? And that can actually help us in deciding whether we need to use that particular treatment in the adjuvant setting, or can we use it subsequently if there is no difference in long-term survival. Disease-free survival has been used for a long time as a good surrogate for overall survival. And in the era of cytotoxic chemotherapy, it has been proven to be as a reasonably good surrogate. But this is questionable whether the same way we can use DFS as a good surrogate for immunotherapy, and even more questionable for targeted therapy. We do not have such evidence yet. There have been several successful examples when targeted therapies have shown that disease-free survival improvement had translated into an OS benefit. One of the best example I could quote is use of adjuvant trastuzumab in HER2-positive breast cancer, which, although the primary endpoint of the trial were disease-free survival, but subsequently it showed that the disease-free survival benefit eventually translated in overall survival advantage. But there have been some some famous failures also, and one of the best examples for that is use of 1-year adjuvant imatinib in resected GIST. In the initial trial, when the imatinib was used for 1 year in adjuvant setting, it showed an impressive hazard ratio 0.35 in terms of recurrence-free survival, but this trial failed to improve the overall survival. And more recently, this European trial, which has a reasonably long follow-up period, although showed an improvement in recurrence-free survival, but it again failed in demonstrating an improvement in overall survival. But subsequently, when 3-year imatinib was used and compared against 1-year adjuvant imatinib, and this updated result shows that it not only improved recurrence-free survival, but also resulted in improvement in overall survival. Highlighting that it's not probably just preventing the recurrences, it's delaying the recurrences, as evidenced by more recently published data of 5-year use of adjuvant imatinib in resected GIST, which is probably even better. So the optimum duration is probably not yet known, and that is influencing the long-term outcomes. Adding to this list of controversy, this recently published adjuvant CTONG trial, this Chinese studies, which compared the use of adjuvant gefitinib as compared to platinum-based doublet and resected non-small cell lung cancer with EGFR mutation, which initially showed an impressive improvement in disease-free survival, but on subsequent follow-up failed to demonstrate any overall survival benefit. Adding to the list is adjuvant sunitinib in high-risk RCC, which showed an improvement in disease-free survival at the cost of toxicity with dose reduction requirement in almost 1/3 patient, half of the patients requiring dose interruptions, and on almost half of the patients having grade 3 and 4 events. But on subsequent follow-up, this trial also failed to demonstrate an overall survival benefit. There's a list of immuno-oncology trials in adjuvant setting which has demonstrated improvement in recurrence-free survival and disease-free survival in melanoma and RCC, but so far we do not have data of mature overall survival data demonstrating that there is an overall survival benefit. Similarly, in resected non-small cell lung cancer, the SciEmpower 010 study, which demonstrated an improvement in disease-free survival and a mature overall survival data. Also highlighting that probably a class of patients are benefiting more even in terms of disease-free survival, that is patients with high PD-L1 and higher stage of disease. And if you look at the list of the immuno-oncology trials where IO drugs are being used as adjuvant setting, most of the trial are using disease-free survival as the primary endpoint, except a few like one is for highlighting is Alchemist IO trial, which is keeping an overall survival as a co-primary endpoint. Otherwise, most of this industry-sponsored trials are keeping disease-free survival as the primary endpoint. And one of the most discussed trial in last 2 years is ADAURA. And probably maybe one of the reasons that this topic has been kept in this particular conference. If you look at the disease-free survival advantages, this very impressive hazard ratio 0.17, which is hardly seen in any of the oncology clinical trials so far. But I would like to highlight here that you are looking at this trial a bit early. This is a 3-year treatment, and you are looking at this trial at a follow-up of median of 2 years, where many of your patients in active treatment arm are actually on ongoing treatment. And we need to look at the situation when they stop the treatment, what actually happens. So far, OS data is pretty much immature, and the curves are practically overlapping.
1 minute left, sir.
Yeah. So, again, I would like to highlight that we actually need to, whenever we see that our trial reporting as a benefit in terms of disease-free survival, we need to see whether the overall survival is improved. If overall survival is not improved, we can actually have this shared discussion with the patient that probably we can use this treatment subsequently. If the OS is improved, we again need to see whether the patients in the crossover has been allowed in this particular trial or not. If the crossover has not been allowed, then the possibility that the overall survival advantages which we are seeing is just because the patients in the control arm have not received the effective treatment. And if there is, despite crossover, there is a good overall survival benefit, that's the situation probably we can take the definitive decision and that the treatment is really beneficial. So having said that, all these endpoints are actually kept as a priority in the different settings. If you have a pharma-sponsored or a regulatory trial where the primary aim is to get the drug approved as early as possible, obviously, these trials would keep the early endpoints, which are easily achievable, like disease-free survival or progression-free survival. But here, the endpoints, generally, they are dependent on the type of and timing of measurements, and which confers a bias in terms of assessment. And the one best example for this kind of trial is ADAURA. On the other hand, an academic trial, which is trying to answer a pragmatic question, would probably keep the most hardest endpoint with an easily measurable ways, which is overall survival. And overall survival cannot be influenced by any type or timing of assessment because that is the universal truth. And one of the best example for these kind of trial is Alchemist. Both these trials are trying to answer the same question, but when we have the early results with ADAURA and with those impressive results, the trial has been stopped early. On the other hand, the Alchemist trial is still ongoing with a proposed sample size of almost 6,000 to 8,000. And these are the kind of the ideal world scenario kind of endpoints in Alchemist trial. But unfortunately, we don't live in the ideal world. There have been, if you see in last 1 decade, there have been very few good academic trials which have had big influence on our clinical practice. On the other hand, you have had plethora of industry-sponsored clinical trials in last few years. Again, I'm not trying to influence you which endpoint to use for your therapeutic decision-making in day-to-day clinical practice. But what's more important that before you take these decisions, you just try to answer some of these questions which I discussed in previously, and choose the best treatment and choose the treatment more wisely. Thank you very much.
Thank you so much, Dr. Prabhat Malik, sir. Now we are moving to our next session, for which I would like to invite our chairpersons, Dr. Natasha Lay and Dr. R.K. Deshpande, sir. Dr. J.P. Agarwal, sir, couldn't join us due to some personal reasons. So Dr. Deshpande, sir, is Executive Chairman and Senior Consultant Surgical Oncologist from Asian Cancer Institute, Mumbai. And Dr. Natasha Lay is a lung side lead and Consultant Medical Oncologist from Princess Margaret Cancer Center and University of Toronto. I request chairperson to proceed with the panel discussion. We are taking Dr. Vanita Norona's panel first, and then followed by this Dr. Ullas Batra sir's panel. Dr. Vanita Norona's panel first.
Great. So I'm not sure what chair people are supposed to do, but I'm really honored to be here. We're really delighted. We know Dr. Mock has a limited amount of time, so we're really thrilled, along with my co-chair, to introduce the panelists. I think you've seen them on the screen. We're really thrilled to have colleagues from India, as well as Dr. Tony Mock and Dr. Lisa Hendricks from ESMO. And we're going to turn it over to Dr. Norona, who of course is world famous with her outstanding work and the team's outstanding work on EGFR mutant lung cancer and randomized trials.
So I would like to invite the panelists. I would like to invite Dr. Natasha Lay, Dr. Anil Tibdewal, Dr. George Karimundakkal, Dr. Anuradha Chaugule, Dr. Bhuvan Chuk, Dr. Prasad Narayanan, Dr. Priyanka Srivastava, Dr. Lisa Hendricks, Dr. Tony Mock, Dr. Prabhat Malik, and Dr. Tilak. Over to you, Dr. Vanita.
Thank you so much. Thank you to the organizers, and thank you, Professor Lael, for the very kind words. I'll just share my screen. So in the next 30 minutes or so, I will try to at least discuss the pragmatic issues that we all face in terms of managing oncogene driver mutated tumors. So I'd like to cover broadly these topics. So biomarker testing at baseline, patients with symptoms, brain metastasis, therapy in the first line, at progression, rebiopsy, second line, oligoprogressive disease, patients with poor performance status, management of squamous cell carcinoma, and adjuvant therapy if we have time. Are all the panelists here, or is Dr. George not here? Organizers, or?
I could see George, yes.
Okay. Okay, hi. So starting with biomarker testing at baseline, so broadly, I'll ask each of the panelists, this is, in what percentage of patients are you performing biomarker testing at baseline? Is it in all patients? Is it in a small percentage of patients? And if you are doing it, are you doing it in tissue, on liquid, or both? And what biomarkers do you test for? So we'll start with Dr. Malik. I think yours is the most similar practice to us, and then we'll go to the others.
Yeah, hi, Dr. Vanita. So generally, we do test for all non-squamous non-small cell lung cancer for 3 common biomarkers that which are being tested in-house. The EGFR, ALK, and ROS1 are tested in each and everyone. EGFR being quite prevalent in our setting, so we have started using liquid biopsy also simultaneously so that we can get the early results with liquid biopsy. And patients who have EGFR, ALK, ROS1 testing negative, subsequently they are sent for the NGS, and particularly for the patients who can afford the specific targeted treatment.
Perfect, perfect. So let's ask Dr. Tilak.
Yeah, good evening, Dr. Vanessa. So in our setup, we generally test for EGFR, ALK, ROS, and then go on to the MET and RET. PDL1 is being done in-house. Otherwise, we generally send the tests outside. We outsource them. We send the tissue. We rarely do a liquid biopsy in the initial baseline testing. We don't have issue with cost as such because it's a reimbursable kind of a situation. Availability of tissue is an issue, especially with small biopsies. Turnaround time is as per standard outside laboratories, takes about 10 days to 2 weeks. The baseline reports are generally well understandable. When it comes to MET, RET, etc., it becomes a little bit difficult to read, and not much of an issue otherwise in the testing.
So is your turnaround time for NGS as well 10 days?
No. NGS takes longer. We do we don't do NGS upfront.
Okay. I'll then roll it over to Professor Lael. I know this is something close to your heart about tissue and liquid biopsy. So your thoughts?
Great. So I think the challenge, of course, is that if you do profiling in both, it's double the money. Because we spent so much money in Canada on drug therapy, it was actually worth our while to make sure people got the right therapy, because actually in Canada, targeted therapy is a little less expensive than immunotherapy. So it was actually worth that extra investment. I love liquid biopsy. We're currently working on a project where we're actually doing it when patients present with radiographic evidence of lung cancer. Obviously in India, that's more challenging, with TB and other diseases, you're going to want that pathology no matter what. But our availability of tissue is a challenge. I would say anywhere up to 20% of patients, need repeat biopsies. Turnaround times for us are still a little too long. We've been able to move to NGS. It takes at least 3 weeks. And so, there are a lot of patients where a simple PCR test or, those one-day EGFR tests can really come in handy.
Perfect. Professor Monk, your thoughts?
Surely in Asia, where we have a lot of EGFR, it is a reflex testing by pathologists to do EGFR, ALK, ROS1, and PDL1 in the same go. For the patient with the difficulty of tissue or insufficient tissue, then we use a liquid biopsy, where we usually use a digital PCR for EGFR. Now, NGS is not covered by reimbursement, so it's only done either by selection of the patient or at so-called when they're proven to be negative on EGFR and ALK.
Interesting. So in your setup as well, you're not upfront doing NGS automatically for all patients.
And I ask, why should we do that?
Okay, perfect.
I mean, it's that because the way you ask the question is kind of expected should be the case. But then when you have an incidence of EGFR mutation in my part of the world, where we have about 30 or 40% of patients having EGFR, you save a lot of costs by just screening out the EGFR first, and then only if they're negative, then we offer them NGS.
Perfect. So I think the consensus from the panel is we need to test all patients and as many as possible. And I think most of the panelists are doing reflex testing, so doing the common markers first and then rolling over to.
So Dr. Nana, if I may just interrupt.
Please go ahead.
So just to put a counterpoint to Professor Monk. So the tissue is an issue. So why can't we just do an NGS upfront? As in, once you get the diagnostic tissue and just send it for NGS, and it does save the time. It does save the tissue, and you get all the markers in one go.
Tissue is a tissue. Money is a bigger issue. so I mean,
if you look at the NGS in India,
the cost of EGFR is only approximately 1/5 of NGS.
So I'll tell you, if you turn around so I'm talking about something like 30,000 rupees, and you get all the NGS done in India, and that's a fairly, I'm talking about the cost, so that will turn out to be something like a good $400. You'll get an entire NGS done, and in the EGFR will cost somewhere around $200 anyway.
Every country their own
something
pricing.
like $150.
And compare pricing one country to the other. In my part of the world, it is 1 versus 5. So, and also the other major point is the fact that reflex testing is actually done by pathologists. So that's actually very convenient in terms of timing. So there's nothing wrong to do EGFR testing first.
in a way is that you are actually getting the most of the patient. Look at it, you may be looking for the uncommon mutation, but honest to my heart, I am not quite sure in India how many drugs is available for the uncommon mutation versus the EGFR mutation. So it's kind of fancy to tell people that I do NGS upfront, but certainly even in United States, I don't think it's being utilized perfectly well. And then we fall into the trap of just getting convinced that NGS are things to go. And that is even for the fact that I start a NGS company in Hong Kong that is under my name. But I don't even promote that myself.
And I mean, I guess it's also the difference between, like Tony, where you work, 60 to 80% of the patients you see have a classic EGFR mutation, right? So it kind of makes sense to do like a 1 day or 3 day test, and then, save NGS for the rest. But I agree, if money and time and tissue were no object, NGS is great up front, but I think it's also sort of adapting to the local realities.
Agree.
Perfect. A quick question for you, George, if you could step in. So the issue with tissue. So how have you come across do we always have sufficient tissue for molecular testing? How often is it a problem?
Most often we get enough tissue because we ensure our patients, when we send them on a CT carotid biopsy, that we get at least 6 scores out of them. That's in a significant number of our patients. Or we do a lymph node biopsies under local anesthesia. That's our most common way of getting a biopsy. We do encounter some problems when we try it from the pleural fluid in case of pleural effusions. But that's a small fraction of our patients.
Okay, perfect. So I think we'll move on to the next question. So this was just a very pragmatic study published by one of my dear colleague, Dr. Avinash Pandey. So this was outcomes with liquid biopsy in the real world setup. He practices in a relatively rural setup. So patients who had poor performance status, who could not get a biopsy done just because they were so frail. They did liquid biopsies, a small number of patients, but they found that they could detect molecular mutations and outcomes were comparable to if they had done a tissue biopsy. So moving on to symptomatic patients. So questions to the panel. So do you wait in all patients for your molecular report? In what percentage of patients do you need to start empiric systemic therapy? So for example, if your patient has a lot of cough or is very short of breath, and if yes, what kind of therapy do you start with? And what proportion of patients do you need to start therapy before molecular reports are available? Dr. Prasad?
So before molecular report comes, I think we start treatment in around 60% of our patients.
So I guess I'm going to ask the question back to you then. What is your turnaround time for your molecular testing?
Maybe around 10 to 12 days.
Okay. So almost 2/3 of your patient, you need to start empiric therapy. So what do you start? Then you start regular chemotherapy?
Mostly they will start on pemetrexed and carboplatin chemotherapy.
Okay. Okay, perfect. Other panelists? Dr. Malik? Dr. Bhuvan?
Yeah, so I would say there are actually a number of patients, I would agree, around 30 to 40% patients who are quite sick, and particularly in this part of the world where patients generally present with a very advanced stage of disease. And many a time they're initially, by GPs, they're initially treated as tuberculosis and subsequently they're diagnosed with cancer. We are generally had difficult time with patients. So generally had difficult time with patients having massive effusions. They become sick quite early. So in these patients, we tend to start them on platinum doublet. But more recently, since, as discussed earlier, that the frequency of EGFR mutation, again, in this part is close to 25 to 30%. So we have started using liquid biopsies in all comers by ddPCR. So we get the results in 3 to 4 working days. And if you are lucky enough and find the targetable alteration in EGFR, you can start therapy straight away. But I would say around 30% patients eventually are started on platinum-based chemotherapy before getting the molecular reports.
So do you ever start on an empiric oral TKI?
Except for very few patients where we can't really do much, very frail and patients. and where getting even a good amount of tissue is a challenge. But nowadays, it's very infrequent.
Okay, perfect. Dr. Priyanka?
Yes, ma'am. My practice is basically a rural-based practice, so turnover time for reports is long. I would say more than 2 weeks. In most of the patients, we start chemotherapy interim.
Okay, perfect.
So just a point here. So I think what we do is we kind of go for if you're treating a non-smoker female in which you're trying to, probably you'll get a EGFR done. So sending a DDPCR and getting a report in 2 days, as Professor Mock said, I think it makes sense. But if you're treating a smoker who has a heavy burden of disease, I think it makes sense that you start him on a platinum doublet and wait for the other molecular markers to come out. I think looking at the patient profile also helps a bit in trying to see if you're going to be expecting a molecular driven tumor in them or not.
Perfect. Professor Mock,
it's interesting.
Do you ever need to
I think
start empiric therapy?
2 points that I want to make in addition to what was said, that which I entirely agree. So the first point is the fact that we have to distinguish between symptomatic versus life-threatening. Symptomatic patient, they don't die within a week, and most of the time that you probably get EGFR data back within a week. Life-threatening is a bit different. In a way that if there's no immediate measure that you can believe it, and then you have to start something. That's number 1 point. And number 2, I think there's sometimes the temptation to give chemo IO because you want to give everything to a sick patient. Now, but be cautious that if you start the IO, when it comes back to be EGFR mutation positive, then you may not be able to start the patient on osimertinib, that the patient may lose chance of starting the target therapy immediately. So we have to be very careful. So I more tend to, if I have to start something empirically, it would be chemotherapy while I'm waiting for the molecular and the PD-L1 status.
Perfect.
I agree with Dr. Mock. In Canada, we have immunotherapy funded. So for most of our patients, we'll start chemo if the results don't come back in time. And then if they're negative, then we'll add the immunotherapy. I confess, though, occasionally, in a 50-pack year smoker, I might start chemo immuno a little faster. But I agree with you guys, if at all possible, to wait for results before adding checkpoint inhibitor.
Dr. Hendricks, we haven't heard from you yet.
I think in the Netherlands it's more or less a similar practice. I think if you're very symptomatic and have a very poor performance status, then usually it's best supportive care. So then we don't treat anymore. I think our NGS reports are quite quick. It's usually 10, 12 days. So usually you can wait. And if you have indeed the never smoker, young adenocarcinoma, then we have the option for a very fast EGFR, ALK, BRAF, ROS1. So that's, that's also an option. Then we have these results in 2 days and then you can start. But we never start immunotherapy without the molecular results. So.
Perfect. So we'll go on to brain metastases. So stay there, Dr. Hendricks. So we wanted your inputs on that. What proportion of patients is everybody doing? Is everyone doing a brain MRI at baseline? So we'll just start with that question first.
Yes. Maybe then.
Yes.
Yes. Yeah. Yes.
Dr. Priyanka?
Yes, ma'am.
Okay. So everybody, I think, is anybody not doing a brain MRI at baseline?
Can I add
something? Dr. Monica, may I?
Of course. Anil, I know your thoughts and I know Dr. Malik's thoughts, but please go ahead.
So if you're talking about metastatic non-small cell lung cancer patients who have already had liver metastasis or lung metastasis or adrenal, we are not doing routinely the brain MRI as a part of investigation unless and until the patient is symptomatic. As a part of staging investigation for stage 1 to 3, yes, we are doing for all patients, but not for asymptomatic patients who have already the visceral metastasis.
Perfect. And I
is it a financial issue or is it a belief issue?
There are actually 2 issues. The first one is the financial, as well as I believe only ESMO guidelines do recommend the brain metastasis in driver mutation population, unless the financial issue is the must. First one.
I can't solve the financial issue, but then for clinical issue, a patient with small metastasis that managed early we can probably prevent the patient from getting to become symptomatic. And also that may also impact on your choice of the TKI if on the other hand, if finance is an issue. Obviously, third generation drug is more expensive in most part. Well, maybe in India, you got your cheaper version. But then for BrainMet outside the India, that they should actually get third generation. And then the cost is actually a lot higher than the first generation, which become generic now. So that is the reason why we do that, yeah.
Can I just ask a question? So if finance is a question, as in if somebody has a brain metastasis and you're starting them on a systemic first generation TKI, how do you start them on a TKI if you have not seen their brain? As in, it's either the patient takes ROSI and then obviously he doesn't have a financial concern. But if the patient is taking a first gen TKI, and then how do you start somebody in a first gen TKI if you've not seen the brain?
I'm sorry, I haven't got the question correctly.
Anil, so Dr. Bhuvan's question is that if you haven't imaged the brain and the patient is asymptomatic with no CNS symptoms, but you are starting gefitinib, you're starting a first generation TKI, how can you do that and without looking at the brain? That's his question to you.
I'm not sure. The TKI should not be started without doing MRI at baseline.
He's saying a non-CNS penetrant oral TKI.
But if the patient does not have any symptoms of brain metastasis, then...
Yeah, so I think we'll roll that back to you, Dr. Bhuvan. So if the patient had asymptomatic brain metastasis and you were starting a first generation oral TKI, presumably in a vast proportion of your patients, are you giving whole brain radiation therapy for asymptomatic brain metastases in driver mutation positive patients, regardless of what TKI?
No. So I'm giving, and to be very fair, I at least try to keep the brain busy under check. And at times keeping doing a 6 monthly or 3 monthly scan to it, whether it is being progressing or not. So my thing is that you have not checked it at the upfront. How do you monitor it? How do you see whether it's going? What is happening to it?
So I agree to you on that particular point, because we are facing a lot of those problems in our brain metastasis clinic because we do not have the brain MRI at baseline. But unfortunately, so my personal opinion is that we should do brain MRI for all the patients, especially in driver mutation patient. But we are not able to do that because of financial issue and because of the guidelines that have not said clearly that every patient should have MRI brain at baseline.
Perfect. So I think we more or less discussed all this. Dr. Prabhat, you were going to say something?
Yeah. So again, first of all, I would say that the reason for saying this is not only financial, but it's the logistic issues also. In the institution where you practice, Dr. Vanitha, and I practice, when getting an MRI date is one of the biggest challenge. In fact, last year we published our one of the paper where we did the CECT scans for brain in all comers. It's a data of almost 500 odd patients, including all stages. And we saw that almost 20% patients could detect the brain metastasis, and more than half of them were actually asymptomatic, which were detected just on a contrast CT. This was kind of approach because of the logistic issues we had. But in terms of practice, all the patients who are being considered for any radical treatment, be it surgery or radical chemoradiation, all these patients undergo MRI. Otherwise, for metastatic disease, unless there is a clinical indication, we do contrast CT for all these patients. That's kind of a pragmatic solution for our own problems.
Actually, in a lot of clinical trials, they do accept contrast CT scan as well. So it's not routinely, that must be, although I preferred it, but I think contrast CT scan is relatively sensitive to pick up a sufficient amount, not the tiny one, but then a good amount of the brain met.
Yeah, it's a simpler solution. You can get it done within a week time here.
Dr. Hendricks, to you.
And maybe to add to the discussion about brain MRI and brain CT, we did a prospective study in stage 3 non-small cell. So yeah, you don't want to miss the brain mets. And after a dedicated contrast-enhanced CT, we found 5% of patients with very small metastasis on a very dedicated brain MRI. But I think in stage 4, yeah, it doesn't really matter if you miss the very, very tiny ones, because if you follow up the brain and if the patient doesn't respond, then you will find them if they are a little bit bigger, and then you can still treat them. So I think upfront brain CT, if it's a dedicated one, then yeah, why not?
Perfect. So if no other comments, we'll go to the next. So therapy in the first line setting. So to each of you, what is your first line therapy of choice in EGFR driven lung cancer? What proportion of your patients can actually afford osimertinib? And if your patient cannot afford osimertinib, what is your therapy of choice?
Before we start, can I ask you the question? Do you give chemo and ARISA in your day-to-day practice?
Yes, absolutely.
Every patient got chemo plus ARISA?
No, not every patient, but yes. So we offer patients osimertinib if they can afford it. A very, very small proportion of our patients can afford osimertinib. And if they don't, then we definitely offer them chemotherapy with oral TKI. But I'd like to hear the uptake
for osimertinib, then you will not give chemo?
No. Okay. Not off trial. Let's go to the other panelists. Prabhat.
Yeah, so again, the proportion of patients who can actually get osimertinib in my practice is maybe less than 10%. So eventually, almost everyone end up getting a first generation TKI. Of late, I mean, the kind of approach what we are following right now is patients having heavy disease burden. Younger patients, generally, we prefer to use gefitinib chemo combination. Patients who are elderly or frail and cannot afford third generation TKI, they are treated with gefitinib and narlatinib. As I said, that we would prefer osimertinib in patients having brain metastasis, but the proportion of patients eventually receiving is again less than 10%.
Yeah, no, I think in our setup, it's maybe less than 5% of patients who can afford it. It's getting better, but certainly a long way for us to go. Dr. Priyanka?
Yes, ma'am.
Sorry, I'm unable to hear you.
Yeah, this sorry, network issue. Yeah, so we are in my setup, very few patients are able to afford osimertinib, so we generally go ahead with the erlotinib, gefitinib.
So single agent or first generation oral TKI?
Yes, ma'am.
Okay. Dr. Bhuvan?
Ma'am, I think what Indian government has done is for the CGHS panel, it has allowed osimertinib. So that has helped a lot of patients to procure osimertinib. However, if you talk about the private sector per se, I think the figures would be same. If that's the patient can't afford osimertinib, we probably go chemotherapy.
Okay, perfect. Dr. Tilak and Dr. Prasad, I think probably larger proportion of your patients get osimertinib?
No, Prasad here. So maybe only 20% of the patients will get osimertinib, and the rest of the patients get the chemotherapy and gefitinib.
You have a rich clientele, still not able to afford it.
Still, it's because it's not the drug is so good that you have to spend money for a long time. So it is not. It's not that you can spend for 4 months to 6 months and then go away from that.
So in our setup, though the patient does not pay for the thing, but the institution pays for the drug, and when it comes to the overall budget, we don't have the luxury of using osimertinib for all the first comers. So I agree with Dr. Prabhat. What with a young patient, large disease burden, we are generally going for a chemo plus TKI. Otherwise, it's just a first generation TKI.
Professor Lael, Professor Mock, is it automatically osimertinib for your patients? Or?
Well, in Hong Kong, osimertinib has to be paid by the patient. So for brain met patient, I strongly encourage them because the data is really tremendously different, for patient with a brain. For patient without brain met, the first generation erlotinib is free in the government hospital. So that is actually more preferable. We hardly ever give chemo plus TKI in the first line.
Professor Lael?
And I think, thank you. None of our patients can really afford it. Even the wealthiest can manage a couple of months and then that's it. So we've been very lucky that the governments have been funding it. For all the common alterations, we have them. And then for everybody else, we do offer afatinib or gefitinib. We haven't been looking at intercalating chemo, but obviously very interesting, great data from your team and others. And in terms of sort of radiotherapy, there's a lot of interest now in oligometastatic body radiotherapy. And so we've got some trials ongoing for CNS radiation plus osimertinib versus osimertinib alone. And then also similarly for body radiation plus the TKIs, looking to see if radiation early versus late is helpful.
Perfect. And Dr. Hendricks?
We are lucky osimertinib or all TKIs that are registered are reimbursed in the Netherlands. So we can just prescribe and the patient doesn't have to pay. The only thing you need to be aware of that the hospital needs to negotiate with the insurance company and you need to guess the numbers for the next year. Otherwise, the hospital needs to pay what you didn't estimate. So yeah, but for the patients, you can just prescribe.
Thank you. So I will skip these slides and so, sorry, Dr. Priyanka, you had raised your hand.
Yeah, I just wanted to ask my colleagues and international faculty, especially, what dose of osimertinib would you prescribe in patients with CNS mets?
I think the standard dose is 80 milligram, and then all the trial, including the subgroup analysis from FORA, is also based on 80 milligram. I don't think there's too much data to suggest 160 is good for, better than 80 in the brain met, but for leptomeningeal met, there is a boom study that using 160. So for the brain met, I think 80 milligram is sufficient.
Yeah, I start with that too. There was a nice study from Nir Pelled's group. It was in one of the neurology journals where they talked about patients that had worsening brain mets on 80 milligrams. And when they escalated to 160, they saw incremental response. Of course, funding and toxicity, a real challenge. But I agree with Tony, I started 80.
Perfect. So we move on to ALK fusion. Sorry. So we'll move on to ALK fusion. So what is your first line therapy of choice and what proportion of your patients can afford some of the newer ALK inhibitors, so alectinib or lorlatinib, brigatinib? And if they can't afford that, what is your ALK inhibitor of choice? Dr. Priyanka, do you want to start?
Ferritinib is currently the most affordable among the most.
Okay, and do you use the 450 milligrams or what dose are you using?
I don't have many patients. Yes, the few which I have, they have been tolerating 450 so far and doing very good.
Okay, perfect. Prasad, are you able to give newer generation ALK inhibitors?
I think the percentage is similar to the osimertinib patients. Otherwise, it is either crizotinib or ceritinib, since we have some support program and the dose sometimes helps in decreasing the cost.
Okay, perfect. Dr. Malik?
Yeah, so again, ever since that 450 milligram of ceritinib with food has become more commonly used regimen in our practice because it's much more cost effective. Earlier, crizotinib was the standard treatment which we have been using, and we do have some support program for crizotinib. We generally discuss the option of alectinib or lorlatinib for first-line treatment in patients with brain metastasis, but this proportion who are actually able to take it is again less than 10%. And eventually, most patients receive ceritinib and maybe early radiation.
And a pretty depressing results from experience from everybody. I think there's so many options, and yet I'm not able to offer them to our patients. Dr. Tilak?
We do use crizotinib or ceritinib, but there have been a few patients where we have used alectinib up on the first line. Remaining, of course, lorlatinib only in second or third line, brigatinib never so far.
Okay, perfect.
So,
Professor Mock, do you automatically use
I still remember,
or?
I still have a very fond memory that I actually come to launch crizotinib in India many years ago. Dr. Verona probably was a student at that time. So, but then, still a good drug is still better than chemo. So I don't think you should feel too bad if you use crizotinib in that way. But on the other hand, for the second generation drug, I will give you a little advice. Anatinib, you can give 300 BD. Honestly, the Japanese data is actually as good as anything else. Even the CNS data is not bad. So of course, the company will tell you that, yeah, you got to give 600, but 300 BD is half price. I give a lot of my patient 300 BD, and that price is actually cheaper than crizotinib. So I especially for patients with brain met, and then I think that we only to the patient to give them second generation TKI. Suritinib 450, I think doesn't go well with curry. So I think you will have a lot of problem with your GI tract, with suritinib, and so I still go for a half dose anatinib if there's a financial issue.
Perfect. Professor Leo?
So again, no one can afford these drugs. We're lucky to have funding support for alectinib, and like Tony, I have no shame in starting people on 300 BID or dropping to that. It is a real challenge, right? When the CROWN data came out, one of the questions from a Canadian oncologist was, why did we do this study? Because, it's so challenging to afford these drugs in the first place. And then sort of there's that desire for sequence. So I suspect that lorlatinib moving to first line will not be as easy as osimertinib moving to first line. But maybe if we see a survival benefit, that will change.
We will have an updated CROWN profession free in AACR.
Looking forward to it, Dr. Mock.
Very exciting. So as Professor Mock and a lot of the panelists have suggested, so we do treat patients with crizotinib. I think that is still our go-to drug. We are using seratinib quite often with the 450 milligrams data, but this is our early data, which Dr. Kumar had also suggesting that, if you are able to expose the patient, the most important is that the patient needs to receive the targeted therapy. So, if you have only crizotinib, they still do well. The patients who received crizotinib had a median survival of 3 years plus. So, still suggesting that, there is a benefit, and that's perfectly acceptable management. How about experience of other of the panelists with other driver mutation positives? And I added NRG1 as well, so not to forget that we have a drug that is relatively affordable in our setup. So if you have a patient with ROS1 positive with brain mets, without brain mets, what is your go-to drug? I think maybe Dr. Anuradha, you're on the panel, and I don't think you've spoken yet. Do you want to comment about testing for ROS1? What would you recommend? IHC, NGS? Dr. Anuradha, are you there?
Sorry to interrupt, but we'll have to wind up in the next 5 minutes.
Okay, sorry. So then I think maybe we'll skip ROS1 without brain mets. Everyone. Yeah. And with brain mets, has anybody tried NTRK inhibitors? So there is a compassionate access program available. Just letting everybody know. So entrectinib is being supplied on a compassionate access program. So that would be something to look into. Is anyone testing for NRG1 in their panels? Because that's not part of our panel. So I have never seen a patient with NRG1. Anybody else?
Yeah, we test.
NRG1 is only hypothetically that we can use a HER3 inhibitor. So right up to this point, I think there's no proven drug. So unless, if it's come free, then we test it. But otherwise, I think there's no point to test for it right now. There's no really established medication for it.
Yeah. I mean, I think in clinic, especially, Tony, it's interesting, right? Because NRG1, all my patients are young Asian males that are 30 years old with otherwise driver negative tumors. So, I think there's a huge market. Like, we've been very excited about the trials. We have used afatinib. Lisa, are you guys using afatinib as well?
To be honest, I think only had 2 NRG1 positive patients, and one was already dead when the results were available, and the other one didn't want any treatment. So yeah. So we test to refer for clinical trial, but then the patients end up not willing to go for the clinical trial.
I was very excited so reading about the afatinib data was very exciting. So hence I added that, because afatinib is very affordable in our setup, although we are not doing the test at all. So I think it's time to perhaps wind up. So maybe just a couple of other points. Asymptomatic progression, how do you manage it? So you've done your scan and you see that the patient has progressed. How do you decide? Do you change treatment? Do you continue your treatment? Do you add chemotherapy? Do you send molecular testing, and only if you find a driver do you change therapy? Just maybe a couple of comments.
Real world kind of a panel discussion. So honestly, ma'am, I think if the patient is asymptomatic, we generally continue for some more time as long as the patient can tolerate it or develops a new symptom. Or if something can be given a local ablative therapy like a radiotherapy or something, we do that. That's the real world practice.
Perfect.
The good old study that we have done with Kunju Park on aspiration study, that by doing that, you actually extend the use of the TKI for about 4 months. So which is actually good for the patient.
Perfect. So continue as long as the patient is doing well clinically. So at progression, what proportion of patients are you able to do a rebiopsy? Panelists, Prabhat? So
yeah, so
before they throw me out.
In EGFR, a large majority of the patients undergo a liquid biopsy. We do a repeat biopsy in patients who can actually afford osimertinib. In absence of that, practically everybody is going to receive chemotherapy.
One of my patients had developed a post-osimertinib ALK mutation, and so EGFR had turned it to C797S, and they developed a ALK mutation also. So I'm still struggling to get a brigatinib, because I think that's the only drug which could fit the entire thing. You could have a EGFR C797S and ALK. So there was a study with the brigatinib plus cetuximab which had done that.
If you take the original biopsy and test for NGS or ALK, you may actually find it in the beginning.
Yeah. So we did that. There's a sequence of foundation studies with that. The first was EGFR standard, and then on progression, and then so basically the patient was started on osimertinib to begin with. On osimertinib progression, she had a RET and a BRAF, and then when she progressed after RET and a BRAF, now she has a EGFR C797S and a ALK. So it's a pretty interesting sequence. It's the way it is developed.
But it's a L mutation or L fusion?
No, it's ALK fusion. Sorry, it's ALK fusion with
L translocation.
Okay.
We also have a patient who has had a sensitizing EGFR mutation and then developed an ALK fusion and progression. So I agree with you, and I looked it up at that time, and it is rarely one of the possible progressive mechanism. So I'll end with this oligoprogressive disease. Dr. Anil, do you want to comment? How do you define oligoprogressive disease, and what kind of therapy do you offer? So Dr. Anil and then Dr. George.
Yeah, so generally in the literature, it has been defined that oligoprogressive disease are generally who are progressing at few sites, especially less than or equal to 3 sites, and rest of all the disease, including the primary, is well controlled on the systemic therapy, whether it can be immunotherapy or targeted therapy. And generally surgery or SBRT or SRS for the brain metastasis is usually offered depending upon the patient condition, specific characteristic of the patient.
Perfect. George, surgery for oligoprogression?
Very rarely. I'd be much more selective, more stringent in my selection criteria. Not 3 to 5. 1 is what the max we've done. And specific sites, lung, adrenal, these would be the preferred sites where I would advise surgery. Otherwise, I wouldn't go for any other site of metastasis. We've also done it for non-region lymph nodes also when they progress. But much more stringent criteria when using surgery as compared to radiotherapy.
I'll skip all of these slides in the interest of time. I think we are keeping Ullas and his panel from dinner. So I just wanted to, any last words from any of the panelists before I end? So this is my wordle from today. So and it struck me that it was very symmetric, and to me this is like how we are progressing in lung cancer. One step at a time, and eventually, hopefully, moving towards a cure eventually. So I'll end with that. Any last words from the panelists?
I have one question for Dr. Mock, if I may, ma'am.
Go ahead.
So what do you think of the crizotinib re-challenge in ALK-positive tumors after the third line or something? There is some data, there's a particular mutation.
Yeah, it is feasible, but the question is whether you're re-challenging blindly or whether you re-challenge after the biopsy. So I think that you probably referred to the famous single patient report in New England by Alex Shaw, is that the patient got a re-challenge and then they were able to find a specific mutation that come back that is actually crizotinib sensitive. So I think the chance of a blindly and able to have especially you already start on second generation TKI, the chance of a blindly and successful and crizotinib is low. But then if you're able to do a biopsy and find one mutation that you know from literature that is sensitive to crizotinib, then be my guess. But then I think that is not a likely event.
Thank you, sir.
Only Alex Shaw can do it.
And I think in the fine print, the patient was having a little vinorelbine at the same time, right? I mean, that might be a great study for the Indian team, right? If you guys could get an ALK inhibitor manufacturer to be interested in this re-challenge concept, and then you guys can publish some great data, right? So you'd have your first ALK inhibitor, you'd have chemo, and then you could re-challenge them. They might pay for you to do translational studies. I mean, that would be beautiful if you guys could put that together.
Thank you so much. So thanks everybody for your insights and inputs, and to dinner. I'm eagerly awaiting Dr. Ullas Batra's panel. Thank you to the
so much for the invitation. I have to sign off. Actually, I got another meeting in New York, so that's why I have to go to the meeting now. So bye-bye.
Bye, Tony.
Thank you so much.
Bye.
Thanks. Bye. Good night.
Yeah, thank you, Dr. Manita, and thank you to the rest of the panelists. Now, without wasting any more time, I'll be inviting our moderator for this panel discussion on a real-world perspective on immunotherapy and NSCLC, implementing state-of-the-art in the clinic. And the moderator is going to be Dr. Ullas Batra. He is the Senior Consultant and Chief of Thoracic Medical Oncology from RGCI Delhi. And the panelists are going to be Dr. Natasha Leal, Dr. Senthil Rajappa, Dr. Abhishek Mahajan, Dr. Navneet Singh, and Dr. Lisa Hendricks. So over to Dr. Ullas, please.
Okay, thank you. Finally, thank you. And by the way the panelists were dropping out, these are only the hardcore medical oncologists that are remaining at the end of 10 o'clock for a panel discussion. Senthil almost looks like in the quilt, almost drowsy, so with a performance status of 3, if not more.
Very soon 4. At the end of the panel, it'll be 5, I'm sure.
Okay. And Senthil, so I would like to ask my first question to you. How much minutes do you want the discussion to be?
End it here, Ullas.
Okay, we will end it here.
Sorry, go on. Always, it's always a pleasure. It's always a pleasure to be a part of your panel. Please go ahead, Ullas.
Okay. Is Navneet there? Okay, Navneet is there. Okay, so we have the right people for this end of session discussion. We have Senthil, we have Dr. Abhishek Mahajan, we have Dr. Natasha, Navneet, and Dr. Lisa. Fantastic. And so I have been asked to moderate I'll finish in 15 to 20 minutes, partly because my wife is waiting for dinner and I didn't have dinner. So let's see this. So my first reactions when I in fact was asked to moderate about the panel discussion on the real implementation of this was like this. So, this is what the real life data of immunotherapy looks like. And this is what the clinical data trial actually looks at. I mean, Senthil, I remember you asking this question to us 6 months back. That is immunotherapy in real life almost effective as what it is in the clinics. My subsequent reactions on that was maybe if the real life data is not very good, you look at Vicky Kaushal, and for both Natasha and Lisa, this is the guy that got the most famous Bollywood actress actually. So even if you're Vicky Kaushal like that, you still have hope. So it is for poor oncologists like us, there is still some hope on that. So let's get real about immunotherapy in the clinics. I looked at some of the data which was published from India in the last 2 years. So this was the real world data of immune check inhibitors in solid tumors from Vanita's group, single center retrospectively 3 years data. And they had out of 9,610 patients, only 155 patients could get immunotherapy, 1.5%. Early data till 18, but some data. This was the data from the Jaipur group. And again, in second line, they had 29 patient data, which was there in immunotherapy. So let's get real about this. This was one more data, which I think we all published in the conference, which was organized by Dr. Prabhat Malik. And again, what we saw in 2020, there were 74 patients of non-small cell lung cancer getting immunotherapy in second line. So this is where we are. So let me ask Dr. Senthil, you first. What proportion of your patients get immunotherapy in lung cancer and in what line?
So if somebody can afford and is an appropriate candidate for immuno, they get it in the first line. I don't keep it for the second line. Roughly around 10% would get it. 10% of eligible patients would get it. Okay, Navneet, how much?
Less than 5%.
Less than 5%. And Navneet is even more drowsier than what you, Senthil, is. So, yeah. Dr. Natasha, how much patients in your setting will get? It's cold, man. Senthil, you don't realize it's pretty cold in Delhi.
Yeah, so technically, I would say that the vast majority of our patients get first line either checkpoint inhibitor alone or with chemotherapy because it is funded through the government. I will say increasingly, I see older, frail patients with squamous lung cancer. And, paclitaxel, carboplatin, and pembrolizumab is a challenge. Nivolumab and ipilimumab plus 2 cycles of chemotherapy is a challenge. So these are patients where, I might give, whether it's single agent chemotherapy or dose reduced gemcitabine platinum, and then actually switch to second line. So those are the sort of select scenarios where I actually still do use second line immunotherapy, because especially if they're going to benefit, I prefer the single agent.
Okay, so Dr. Natasha, you said if you have a patient who's elderly, will you always use a keynote 189 or 407? Or are you open to use immunotherapy with GemCarb or weekly Pacli carbs or something of that sort?
Yeah, so we tend to follow the trials. I have used Gem Platinum with Pembro safely and other drugs, but we have been tending to use it according to the study protocols.
Okay, Dr. Liza, how much proportion of your patients get IO in first line?
I think in our hospital it's around 60–70%. We have a Dutch registry where all patients with cancer are entered. And if you look just at stage 4 non-small cell, then approximately half of the patients get any treatment. But usually those that are not treated are either 80 plus or have a very poor performance status or whatever. And those that get treated, if they don't have an oncogenic driver, usually have chemo, immuno, or immunomono, depending on. Usually they don't receive chemo anymore. But we stick to the trial regimens because other regimens are not reimbursed, and then we have a problem.
Okay, let me get either Dr. Vanita or Dr. Kumar on this if they're still there. Vanita, you are there. I asked you, I have a data of 25 patients of immunotherapy in first line PD-L1 more than 50%, and you said 2 less. I didn't look at the data of that. So how much data do you have of yours in first line NSCLC, first line IO, Pembro as alone or in combo?
We have a fair number. Again, the proportion of our patients who are able to afford it is small, but I think just because of the sheer volume of numbers, we do have a fair experience with using it.
Ballpark figure.
400–500 maybe.
Of first line immunotherapy?
Yeah.
Oh, that's fantastic. That's actually fantastic. That's something which is very good. So I thought we will.
You're talking over the last few years, no?
I'm talking about the last couple of years. Okay, fair enough, but that's a good one. So let me start with this. There's a lot of talk of NGS actually in the panel, which is moderated by Dr. Vanita. So we have a 55-year-old female who was diagnosed as CA lung with stage 4 adenocarcinoma lung, some pleural effusion and bone mets. The pleural effusion was moderate, drained. She's PS1. Her EGFR IL cross was negative. PDL was 55%. This is what usually happens. She was counseled regarding immunotherapy. They wanted time to decide because the money is huge. We also sent for NGS. The report was awaited. We started the patient on pemetrexed carboplatin. The tolerability was well. In 2 weeks' time, the NGS report came, and that showed a K12C mutation, or let us say it might just show a BRAF mutation. And she's also willing for immunotherapy. So what I'm basically asking you is, what we all know that in EGFR ALK ROS rearranged patients, we will not give immunotherapy. But will you give a single agent chemo immunotherapy alone or in combination in the remaining 6 biomarker altered patients? So let me start with Navneet, and then I'll go to Senthil.
KRAS is fine. Okay.
KRAS is fine. So let me ask you, Navneet, KRAS is fine, BRAF is fine.
I didn't say BRAF.
Okay, I'm asking you. Okay, KRAS is fine, BRAF?
BRAF, I would still tend to offer them a BRAF inhibitor, but KRAS doesn't mandate not withholding immunotherapy for a high PD.
So the KRAS is okay. BRAF is not fine. The other one, the RET and the NTREX and the MET exon 14.
So all of them, the targeted therapy would be preferred. So in them, it should either be just chemo or chemo immuno at best, and targeted therapy whenever feasible. But KRAS is separate.
So KRAS is separate. Other than that, you are okay with giving only in KRAS you're okay to give. For BRAF, MET exon 14, RET and all, you will not add immunotherapy. Is that what I'm getting, Dr. Navneet?
I will not give monoimmunotherapy.
But immunochemo is okay.
If the patient has no access to the appropriate targeted therapy, then you could give the combo.
Fair enough. Senthil.
So if it is KRAS G12C and you want to do monoimmunotherapy, that's fine. But in none of the other driver alterations would we use monoimmunotherapy. That's point number one. In the other alterations, I would be hesitant, or I would not use a combination of chemo immuno also, because we know that the incremental benefit of adding immunotherapy, if you have a driver mutation, barring KRAS G12C, is hardly any or none. So I wouldn't really add in a situation like that. Now, coming to your patient in particular, in this patient with a PD-L1 of 55%, being a lady and the usual Indian lady that we see is a non-smoker, even though the volume of disease that you're seeing is not very significant, I would still be very hesitant to use monoimmunotherapy for obvious reasons, because there is some data based on subgroup analysis to say that this is typically the kind of patient who is less likely to benefit from monoimmunotherapy. A lady, a non-smoker with a PD-L1 just around 55, it's not a contraindication to use, but I would be very hesitant to use immunotherapy as a single agent in this lady, not because of KRAS G12C, it's because of the other clinical characteristics that you're putting up.
Fair enough. So the IO chemo is okay. Only mono IO is not. Is that what I'm getting from you also?
So for me,
non-KRAS.
Non-KRAS, even chemo IO, I would not use.
Okay, and chemo IO will. So in other words, we are now advocating, since Tony Mock has gone, that we do NGS in all the patients before we put them on immunotherapy.
Absolutely. If we're going to use immunotherapy, then I would certainly want to do NGS to make sure that you're ruling out all the driver mutations before you say it's okay to go ahead and use immunotherapy.
Okay, Dr. Lisa
Natasha wants to say something.
Lisa had a very nice smile on the face the moment I said Tony has gone and we are getting NGS. So Lisa, your comments.
Yeah, sorry, we always try to do NGS before we start therapy, and usually it's feasible. So yeah, we wait, and also we have first-line trials, for example, for RET fusion. So you also don't want to miss these patients. So wait.
So can I ask you? Let's say it's not. Dr. Natasha, just give me a sec. I'll just ask Dr. Lisa once to get my pound of flesh from her first, and then go to you. Okay. So let's say if it's a MET exon 14 MET or a MET exon 14 MET or a RET, would you be okay in giving chemo immuno?
No, I think for RET, I really don't like it. Yeah, first for RET, we have a clinical trial ongoing first line, so I would try to enroll the patient in the clinical trial. And we can give RET TKI in second line and beyond in a compassionate use program. Okay. And those that had immunotherapy before, we don't have many patients, but they all developed the pneumonitis. So I would really avoid immunotherapy in these patients. And also the data with immunotherapy and RET are not that great. I think for MET exon 14 skipping, I would avoid monoimmunotherapy. In general, the data is not good. I'm not aware of chemo immunotherapy data in MET exon 14 skipping, but so far I didn't see lots of problems with MET TKI after immuno. But again, we can also give MET TKI upfront, so why not?
Okay, Dr. Natasha.
Oh, thank you. So, I must say that in my clinic, the most important question is does this lady have tobacco exposure? Is she a smoker? Because I think that really remains the most practical indicator of long-term benefit from checkpoint inhibition. So, that's my question. In Canada, we have very good air quality. So I don't know in some of the real world studies, if in India, biomass and pollution also impact. Sorry, I think so I think it's so important. I will say that, in our experience, and we're actually going to publish our MET data shortly, we've actually seen significant activity in KRAS of all types, particularly with smoking activity in MET mutant lung cancer patients, particularly with smoking history, and of course also BRAF V600E. Before we had the targeted therapy, all of my patients that received checkpoint inhibitors are still in remission. So I think those are the three big areas. I agree with Lisa, EGFR, ALK-ROS1, RET, TRAC, and NRG1 fusions. Those are kind of throwaways. I don't really waste, and HER2 to the same extent. That's sort of very low return for your investment. But I think for sure the three associated with smoking, there's a lot more interest. It would be interesting to hear from you guys. Like, does air pollution induce sensitivity to checkpoint inhibitors, or is yours tobacco related as well? There's a lot of good data about that.
So there is no data regarding that, Dr. Natasha, but the point is that we get a lot of women with the non-smoking, at least in the polluted Delhi and the NCR region part over here. But we do have a lot of EGFR mutations also with them. I'm not sure we are analyzing our data of co-mutations in them. So let's see what the data comes up. And my second question to you was, to all of you was, is the reluctance to use immunotherapy because of the lack of efficacy? Or is it because of the, as Tony Mock said, that if you give them pembrolizumab and the half-life is 3 months, you can't use them the other TKIs later. So is it because of the lack of efficacy, or is it because of the pneumonitis effect? Any one of you can take. Dr. Natasha?
I'm sure it's the toxicity that gets everyone excited, right? It's just from that very nice paper from Eddie Guerin's team, with patients who died, and the only person who responded with first-line pembro and PD-L1 high EGFR mutant disease was a patient who actually had wild type. So I think it's toxicity that drives us. I think it's important to remember it's not just pneumonitis, right? Hepatitis can be a big challenge in clinic with TKIs and that sort of overlap of checkpoint inhibitors. But I will say to my patients, like, if you can get the targeted therapy, it's best, it's more efficacious. And especially in India, right, where the costs are so high, why would you bankrupt yourself with pembrolizumab when you could, have a TKI or chemotherapy that works, especially in those kind of groups with less benefit.
Okay, so Senthil, forget the good biomarkers. Let's get the bad biomarkers. What about the STK and KEAP mutations? Let's say you do an NGS and you get a KEAP one mutation which comes out of that. Would you want to get, and the PD-L1 is 55%. Immunotherapy, IO chemo, no immunotherapy, nothing. Send them home.
Good question. So that's, as you rightly said, Ullas, it's not a negative predictor of activity. It's a prognostic marker. It's a bad prognostic marker. So irrespective of what therapy you're going to use, this patient is going to do poorly. So in a situation like that, you are likely to have only one go at your patient and you want to put your best foot forward. So in a situation like that, if the patient is fit and is ready to take a combination of immuno and chemo, that's what I would prefer using in this set of
so
patients.
IO chemo, yes, even if it's a KEAP or some mutation. Dr. Navneet.
So this is data which is not yet ready for routine use in clinic. They are indicators of probable immunotherapy resistance, probably poor response. They may be negative prognostic markers, they may be negative predictive, or both. We don't know yet that. But as of now, it doesn't really change decision making.
So IO chemo or single agent IO for you also. Fantastic. I know they are not markers for clinical interest, but I saw the list of my panelists and I had to step up my disco questions. That's just like that. Dr. Lisa.
No, I think not much to add. I think for now, yeah, well, it's not in our panel, so I don't need to think about it in daily clinical practice. But yeah, if I would encounter it, for now, it doesn't change my clinical practice. It's mainly unplanned analysis, retrospective analysis, and it's for sure a negative prognostic marker. So you can discuss that outcome will probably be less, but I'm not using it for clinical decisions.
Dr. Natasha.
Agree. I'm not using it either. I will say that, there's a lot of interest in this KRAS plus SDK, G12C plus SDK11 co-mutations. So we have been testing it in particular because we're putting those patients on KRAS inhibitor trials. But that's just research, nothing standard. Keep one, it is hard to get. You need a huge panel. And let's face it, it's really just a poor prognostic marker, so I don't use it. I don't need to know.
I think the take-home message regarding STK and KEEP is, to me, is don't include them into your panel. If you don't test for them, you won't find them, and you will be bereft of easy answers, difficult answers over there. Let me go to the second one. So Navneet, I told you I've been looking for questions to match your standards. So the immunotherapy and autoimmune disorders. So this is just another patient which comes to us. You are a 55-year-old female, again the same, stage 4 NSCLC, lung, pleural effusion, bone. PDL1 55%, NGS negative, no actionable mutation. She was counseled regarding immunotherapy, willing, but she has a past history of rheumatoid arthritis. She's on HCQS, she's not on steroids. She says in the winters, I feel my hands do get a bit of stiffness. What do you do? Immunotherapy alone, immunotherapy combo, no immunotherapy?
It's a difficult decision. I would always get rheumatology opinion. In fact, to be very frank, I very recently had a male patient who not just had rheumatoid arthritis, he had hyperthyroidism on treatment, COPD, oxygen dependent, and a high PDL1.
And you did immunotherapy?
No, I have not given immunotherapy. I got clearance from both rheumatology and endocrinology that you could give immune checkpoint inhibitors. His prednisolone requirement was less than 10 per day, but I started him on nab-paclitaxel, carbo, weekly, this thing, and he's actually now off oxygen, and he's still asking whether he can go on to immunotherapy, but I have been very cautious. Yeah. I really don't want to risk somebody getting a... This is obviously a separate scenario, but I guess you have to discuss the pros and cons.
Okay, the PDL1, Dr. Vanita, was 55%. I've written over here. Okay, Dr. Lisa.
Assuming this is a patient with a smoking history, at least consult with rheumatology. And if the patient is willing to discuss the risks, we have given immunotherapy to patients with rheumatoid arthritis without any problems, or just a little bit steroids sometimes necessary, and that's it, and they're responding and doing well. But we also had very, very invalidating joint problems, that patients barely can function, and that you just cannot get it under control despite extensive immunosuppressive drugs. So patients need to be aware that even with a complete response, because this patient had a complete response, she doesn't have a quality of life. So yeah.
What would you, if I ask you for a second opinion, what would you say? Yes or no?
Yeah, I would advise try it, but be aware of the risks.
Okay. Dr. Natasha.
I agree with Lisa and Navneet. And I think, in the old days, we thought it was a 25% risk of exacerbation of the underlying autoimmune disease and 25% risk of new things. I actually think it's more like 100%. They are going to get something. I recently treated a young guy with rheumatoid that was under control. He has horrifying psoriasis, grade 3. He developed fevers, transaminitis, you name it. His tumor did not respond. So again, it would be interesting in these people with autoimmune disease, is their tumor inflammatory because it's sensitive to checkpoint inhibition, or is it inflammatory just because they have such overactive immune systems? So, it's a group for further study for sure.
So this was an article that I got from Journal of Thoracic Diseases in 2020. They said people who have a non-life-threatening AID, non-neurological AID, and good control, you can actually give. And but the flare-ups occurred, as Dr. Lisa rightly said, in 63% of people. So get your documentation properly, warn the patient properly, and I think then we can go ahead actually. That was another one. So let's just go on to the meat of the matter. Immunotherapy in PD-L1 more than 50%. I think we have a lot of options over here. I'm not really going to discuss that. We all know pembrolizumab and single agent and stuff like that. So let me ask. This was the real world data which Solange Peter presented in the first ESMO virtual plenary, and it basically showed that IO chemo combo was not really required in most of the patients with liver diseases or any brain mets, etc., except for smoking. I think Dr. Natasha Lee was the moderator in that session, if I remember rightly. So Dr. Natasha, your take on, so let's say you have a non-smoker lady with 70% PD-L1, your take, single agent IO or IO chemo?
Yeah, I would always make sure these patients get some chemotherapy, chemo, immuno for sure. And so, like I said, smoking is a huge factor in my decision-making. And it would be so interesting to know sort of what air quality changes for things in India. And I humbly apologize. This is a fabulous panel discussion. I'm late for a grant meeting and everybody's yelling at me. So I'm so sorry I have to go, but I'm truly honored to be here. And I wish you guys all the best and that Dr. Hendricks has a wonderful vacation.
Sure. Okay, so we have now 3 hardcore medical oncologists remaining. That's, I think, just a sign for me to sign off. Thanks, Senthil. Just 2 more things from my side. This is for you, Dr. Liza. This was Checkmate 227 showing Nivo plus EP in PD-L1 more than 50%. And this basically shows that there is a fantastic response. And then when ipilimumab to pembrolizumab came together, the graphs were overlying. So what happened? Any scientific explanation or something? What happened?
I think something like statistical chance that something is positive or negative. Yeah, and to be honest, maybe a subset of patients will benefit from a combination of IO, and PD-L1 high, but so far we didn't identify that patient population. And for me, it would be mono immuno unless, so for example, if you have a patient with a no smoking history, then I would really make sure that there is no target. So check the NGS results, maybe do a new biopsy, because usually if you check again, you find something.
Okay.
And otherwise chemo, immuno, and a never smoker.
Fair enough. So my last question to Senthil first. Senthil, your choice of immunotherapy in PD-L1 less than 1, Keynote 189 or Checkmate or 227? Or only chemotherapy?
Okay, less than 1, isn't it? So yep. If it's an adenocarcinoma, it's usually Keynote 189.
Okay.
If it's squamous cell carcinoma, though I have not used yet, but the data for 9LA looks very, very attractive.
Okay.
If it's squamous cell carcinoma and it's less than 1 PD-L1. So that's how I would split up with you.
Dr. Navneet.
I believe the Pembro trials have been the cleanest trials and the most convincing results, whether that has been mono or combos. And so if it is less than 1%, squamous 407, non-squamous 189, assuming EGFR al cross is negative.
Okay.
I am not enthused by these combinations of
no 2-drug chemo light combination, chemo free. Dr. Liza.
If a patient is fit, you use the 3-drug. I mean, you use 2 chemo drugs and 1 IO. Okay. Not fit, then just go on to either reduced dosage or some other form of.
So we are 1:1. Let Dr. Liza decide.
Well, for me, it would, well, the only thing we can prescribe is chemo immuno. So the Keynote or the Empower. Then, why give a 4th drug if, you don't have a hint that results will be better? I think the results are the same. Okay. We cannot prescribe at the moment Checkmate 9LA.
Okay.
Maybe that is something indeed for the PD-L1, especially the squamous, because the Keynote 407, the curves, split but then come together again. Still some censored cases, but that could be an option. But so far I cannot prescribe it.
Okay, last question to Dr. Abhishek Mahajan, who has been waiting very, very silently. Do you actually follow them up with PET CT scans or the CT scans? And how commonly have you seen pseudo progression, hyper progression in an IO chemo combo? Dr. Abhishek is there? Okay. I kept on saying, okay, he's there.
Follow them up with the routine CECT as protocol of the regular follow-up. We don't do a PET CECT. and the chances of having hyperprogression is very rare. We have only seen, I would say, in my experience, under 1% of cases. Pseudoprogression is been more challenging after COVID, where we have seen like multiple patterns because of COVID. But before COVID era, I would say it was under 6%.
Okay, Dr. Navneet, pseudoprogression, hyperprogression, IO chemo combos, first line.
IO chemo combinations, hyperprogression is uncommon. That is a scenario most commonly with monoimmunotherapy. Okay. Pseudoprogression, the problem is if you start doing scans very early for a stable patient. So typically I wait for 4 or 5 cycles or 6 cycles, 3 months on treatment, and then do a scan if they are clinically stable.
Okay. So don't do scans, don't do NGS, don't do keep. That's the mantra today.
Okay. Don't go to hospital. Don't go to hospital. That's even better.
Like other parameters which we tend to forget, like apart from imaging, which might guide you to pseudoprogression, the hormonal profile, and also the changes elsewhere. Like if you are looking at the thyroid profiles and other things, which are more common than the pseudoprogression happening in the lung itself. So, are we really looking at the clinical profile of the patient to pick early pseudoprogression? That's my question.
Okay, so Senthil, you want to take that? I think we do regularly. We do. I mean, all these hormonal profiles. Senthil, you take on this.
How do you manage patients progressing on immunotherapy? Is that what you're asking about? That question, or the pseudoprogression, hyperprogression?
We do depend on pseudoprogression in lung, but are we looking at pseudoprogression, which are the other clinical markers? Like the hormonal profile is, I think, the early marker of patient undergoing pseudoprogression.
I don't know. I'm sorry. I'm not aware of anything.
We've done a study on endocrinological abnormalities on patients on immune checkpoint inhibitors, and it has been reassuring. It's not very common. In fact, even outside of this study, I routinely get a thyroid profile every 2 or 3 cycles and a urine analysis every 2 or 3 cycles, and it is not something which has really caused treatment interruption, barring a couple of patients in whom it really shot up and I had to stop immunotherapy. So just the way you monitor routine blood work, I think thyroid profile has to be sort of done the same way, although at a lesser frequency. Okay. And short of CT scans, you can always get chest radiographs, which are simple to get any idea if you have a suspicion of pneumonitis or anything like that, even though they may not be very sensitive.
Okay, so I think that was my last question. And this is to conclude. I think we are moving towards hope. Hope in the sense that immunotherapy has gone from second line to first line to adjuvant to new adjuvant now. And definitely there are exciting times ahead. So for the people who are really awake right now, thank you for bearing with us. And a special thanks to Dr. Liza for staying, and handed back to the organizers. Thank you.
Lovely, Ullas. Enjoyed as usual, even though it's midnight for me. you lived up to the midnight masala that I said.
And then we will talk about this later. Bye.
Enjoy. Thanks so much.
Thank you, everyone.
Thank you, Dr. Ullas and the esteemed panelists. Now I request Dr. B.K. Smriti to give the final remarks. Over to you.
First of all, I would like to thank all the panelists and the speakers as well as the moderators. And we are extremely sorry that there was such a delay. But I think the discussions and the talks were such that we didn't want to cut in. And I really thank my international panelists also for staying on, and all my national panelists who really cooperated. And now I would hand over to Dr. Kumar Prabhash, whom I would really thank for putting this program together. And I would like him also to take and wish all the panelists and the staff, those who took part in the symposium.
Thank you, madam. I think so. Thank you, everyone. This happened because of everyone coming together, especially ESMO, the ABC, the panelists, all the faculty, especially the foreign faculty and the audience. Thank you all. Thank you so much. And Ullas is smiling, so special thanks to dear Ullas.
That's
always nice to see.
Shouting at me from there.
Oh, good. So everyone is getting shouted. Thank you.
Enjoy your dinner and good night. Good night, Kumar.
Good night. See you tomorrow.